is a land of youth, a land of energy, vitality, and ambition. However, there's an increase in the prevalence of lifestyle diseases, that is, diabetes and hypertension. Risk factors responsible for these conditions are stress, sedentary lifestyle, obesity, smoking, and excess alcohol consumption. These lifestyle conditions are also affecting their vitality and energy, and in turn leading to one prominently occurring condition of erectile dysfunction. 52% of Indian males aged 40 to 70 years are suffering from ED, leading to decrease in their confidence level. Healthy sexual life helps in maintaining the feeling of youth and overall well-being in sexual disorder like ED. Zydus Fortisa, a division of Zydus Healthcare Limited, presents Men's Sexual Health Portfolio, which comprises of Penegra, Zydalis, You Desire, Sustanon. Penegra is the #1 prescribed brand of sildenafil with half-life of 4 hours, duration of action up to 8 hours. Penegra can be recommended for moderate to severe ED patient, long-standing diabetes patient, as efficacy is independent of age, duration of ED or diabetes. Zydalis is a brand of tadalafil that comes as mouth-dissolving, mint-flavored tablet. Zydalis has longer duration of action up to 36 hours with no dietary restrictions. Recommended for the treatment of younger 40+ mild to moderate ED patients. Provides spontaneity and better patient compliance. Sustanon is a brand of testosterone used in the management of ED with hypogonadism. Sustanon shows considerable increase in duration and maximum level of penile rigidity. Improved libido in hypogonadal men. You Desire is the brand of Udenafil, which gives assurance of efficacy and safety. Help your ED patients to feel youthful and maintain overall well-being with the benefits of Penegra, Zydalis, Sustanon, and You Desire. India is a land of youth, a land of energy, vitality, and ambition. However, there's an increase in the prevalence of lifestyle diseases, that is, diabetes and hypertension. Risk factors responsible for these conditions are stress, sedentary lifestyle, obesity, smoking, and excess alcohol consumption. These lifestyle conditions are also affecting their vitality and energy, and in turn leading to one prominently occurring condition of erectile dysfunction. 52% of Indian males aged 40 to 70 years are suffering from ED, leading to decrease in their confidence level. Healthy sexual life helps in maintaining the feeling of youth and overall well-being in sexual disorder like ED. Zydus Fortisa, a division of Zydus Healthcare Limited, presents Men's Sexual Health Portfolio, which comprises of Penegra, Zydalis, You Desire, Sustanon. Penegra is the #1 prescribed brand of sildenafil with half-life of 4 hours, duration of action up to 8 hours. Penegra can be recommended for moderate to severe ED patient, long-standing diabetes patient, as efficacy is independent of age, duration of ED or diabetes. Zydalis is a brand of tadalafil that comes as mouth-dissolving, mint-flavored tablet. Zydalis has longer duration of action up to 36 hours with no dietary restrictions. Recommended for the treatment of younger 40+ mild to moderate ED patients. Provides spontaneity and better patient compliance. Sustanon is a brand of testosterone used in the management of ED with hypogonadism. Sustanon shows considerable increase in duration and maximum level of penile rigidity. Improved libido in hypogonadal men. You Desire is the brand of Udenafil, which gives assurance of efficacy and safety. Help your ED patients to feel youthful and maintain overall well-being with the benefits of Penegra, Zydalis, Sustanon, and You Desire.
Aishwarya, you start. Good evening, friends. Welcome you all to this webinar with international sexperts. Thanks to our Zydas company, Indian company, doing a very immense service to the healthcare providers by providing online education in the form of webinars. We are conducting this regularly once a week on one or other matter on the sexual matters. Today, we are going to discuss sexology in certain aspects with international experts. That is the beauty of this webinar. If you look at it, today the current world population is 778 million population is there, among which the sexually active population is 392 millions, among which the people suffering with sexual problems is 131 millions, a huge proportion. At the same time, if you look at Indian population, it is 138 millions. Sexually active age group is 70 millions. People suffering with sexual problems is 24.5 millions. You can imagine the magnitude of the problem in the society and the need for sexologists or sexual health professionals. This speaks volumes about it. If you look at the historical aspects, history of the human sexuality, every country, every culture has done a lot of research and produced books on this. But in the modern era, the research just started 125 years back only. Prior to that, it was only just all the whatever is based on the observations and because of the people taken from the books only given as a guidance. Hence, all the sexual problems till this modern sex research viewed as only two types. All the sexual problems in the woman are considered as a frigidity, and all the sexual problems in the men are considered as impotency. As I told you, the modern research started just 125 years back, thanks to a lot of stalwarts in this, Havelock Ellis and our Kraft Ebing, Sigmund Freud, Alfred Kinsey, Magnus Hirschfeld, Masters and Johnson, true pioneers. They do the research in the laboratory using the human volunteers. And Helen Singer Kaplan and many more are there, named and named. And all these people could see that the human sexual response will have, people will have a lot of sexual, variety of sexual problems. All these sexual problems for easy understanding purpose can be classified into 6 groups. I have quoted with the color for first 3 groups because they are more common in the community. Then next 4, 5, 6 are less common. That is the only reason. So all these sexual problems now to discuss in this webinar, lot of international experts are participating. Please give them a big round of applause. Dr. Shalini Andrews, please give them a big round of applause. She is Secretary, British Sexual Health Medicine. She is a member, exam committee in ISAM, and she is a well-known figure in the field of sexology. She is doing a lot of work, and we welcome you, madam. At the same time, another good friend of mine, I can consider him as the father of Bangladesh sexology. He is the one who started sexual medicine there to educate their healthcare providers. And he is the president-elect for SASAM. It's a very proud of us. And we appreciate you, sir. And he's a member of ISAM and he's associate professor of psychiatry in BSSM, that is Bangabandhu Sheikh Mujib Medical University. And he is a practicing sexologist and psychiatrist from Bangladesh. Welcome you, sir. Give them a big round of applause. And our another person, Indian pride, Dr. Ritu. She is a senior consultant of obstetrics gynecology, and she is a honorary professor in WIMS Medical College, Gajrula, and she is practicing at Pune. Welcome you, madam. Now I request Dr. Shalini Andrews to start her presentation.
You need to stop sharing. Oh, yeah, thank you.
Yeah, you share, madam. You start your presentation.
Lovely. I'd like to thank the organizers of this webinar for kindly inviting me to do this talk. It gives me great pleasure to do this talk, particularly to my home crowd, and I know that many of my friends and family are watching this today. So my topic is about myths and misconceptions that affects us sexually. So I'm going to talk about why it's important for us. So this talk is targeted at doctors, at clinicians, and also sex therapists and psychologists who will be dealing with these problems. So people who are seeing patients. I'm going to illustrate my points with 4 cases. And finally, I want to finish with a little thought on, do myths matter? Do they have a positive role in sexuality? And that's what I'm going to finish with. So why is it important? When I think about myths and mythology, myths and misunderstandings about sexual medicine, the first thing that comes to mind is this person. He's our illustrious next speaker, and I'll tell you in a minute why. And it's related to this place, which is St. Catherine's College in Oxford. And this group of people, who are a group of sexual medicine experts from Bangladesh, India, on to England, and all the countries in Asia and Europe in between. So this particular group of people met about 10 years ago in St. Catherine's College to talk about, to learn about sexual medicine. So this was the European School of Sexual Medicine. And our illustrious speaker, he comes in on the second day because it does take some time to sort out visas and get there. And he sits in the back. And we were talking about a sexual problem when he suddenly puts his hand up and said, it's not just the science, it's also about myths and misconceptions. And he said, oh, it's so difficult dealing with it. All heads, all 28 heads turned from the front to the back to look at him. And for the rest of the day, we talked about myths and misconceptions. We went on and on and on. It was so exciting and so fascinating. And we haven't stopped that conversation yet. 10 years later, we're still friends, many of these people in this group. And when we meet, we still talk about myths and misconceptions because it's a huge challenge for people dealing with sexual problems. Not just a challenge, it's also a fascination. And it's very interesting. I can never stop telling stories about myths and misconceptions. And that is why I think it's really important. And when I'm going to talk today, I'm going to refer quite a lot to the implicit model. And I'll tell you what that is. The reason I often bring this up is when I meet friends. So recently we had a medical school reunion and I met a urologist friend and he said, oh, it's fascinating what you do. I wish I had an expert like you in my department. I could refer all my patients to you because we see so many of these problems. And my key thing to anybody sitting out there in the audience who wishes that we in this panel were sitting next to you in your department, I want you to go back thinking you can actually do some of this. When we think about dealing with sexual problems, the majority of the patients fall in the bottom of the pyramid, the green bit. So what they need is permission from us that it's okay, whatever they're doing is right and they can go on. They need a little bit of information about sexuality. And permission giving and limited information anybody can do. What I don't want you to do is make it up as you go along. It shouldn't be based on our own myths and misconceptions. It should be based on the science that we learn. So stay educated, and after you attend these webinars and attend a few courses, hopefully you will have the tools needed to give the permission, to give them limited information. Specific suggestions takes a little bit more. We give them specific ideas on how to deal with their problem. And intensive therapy is what comes into the remit of some of the panelists, which takes a lot of training and education to actually be able to deliver that. And when it comes to myths and misconceptions, we need to listen to what they're saying to actually understand, is it a problem? Are they actually telling us it's a problem, or is it okay? And what is the problem? Because when it comes to communicating about sex, people have various ways of telling you what a problem is, and that may not be the problem. So before I start, I have a quiz. I know everyone likes a quiz. So I have 4 questions, 4 statements. And I want you to think about these statements and in your mind, find me the answer, true or false, and have the answer in your head, and we'll come back to it in the end. First question, or first statement: frequent male masturbation leads to loss of energy. True or false? Question number 2. Women who masturbate may lose the ability to enjoy pleasure from normal sex. Question number 3. Vaginal orgasms are better than clitoral orgasms. Number 4. Anal sex increases the risk of infections. So 4 questions, have the answers in your mind, and we'll come back to it in the end. So I start off with my first patient, who's Mr. A. And these are all 4 patients coming, they're from the Indian subcontinent, people I've actually encountered in real life. I may have slightly modified the story to make them anonymous, but these are real life encounters. So this one is a 31-year-old businessman. He's been married for a year. It was an arranged marriage. He was in love from the age of 18 to 23. It was a family friend. And he liked her very much. I think she knew about his feelings, but it wasn't expressed. Not much happened. When they were 23 and she was getting married, he was still not established in life. He'd done his BCom, he was still studying, and she got married to an engineer who was older, doing much better in life. And he didn't even get a chance to say that he might have wanted to marry her. He was very depressed. He was depressed, he said, for nearly 4 or 5 years thinking about it. But then he subsequently went on to do really well. So what he did was he went on and did a business, and the business was flourishing. He has enterprises in different towns, and he travels quite a lot. And when he was 30, his parents said, come on, son, time to get married. They found a beautiful wife for him, and they got married. On their wedding day, there was a drama. So anybody who comes from our part of the world knows that there is always a drama on the wedding day. The boy's family and the girl's family, there's lots of issues, discussions, and through in the middle of all that, the bride faints. So the doctor is called, and by the time she is better, she's had something to eat. Most of the wedding party's over, guests have gone home, and they sit together. It didn't affect their relationship or how he felt about her, but they didn't have a first night, as we say, which means they didn't have sex on the first night together. Of course, he said, look, you're tired. Let's just rest. Let's take it easy. Let's not push it. And then for the next few days when he was there, he couldn't quite manage to have an erection. He left, and then she moved into his town. She stays with his parents, and he travels quite a lot. He comes back, but he's been avoiding intimacy for the last year. So every time it's time to go home from his business trip, he tries to find an excuse to stay away. He talks to her on the phone. All that is fantastic. They can do all their sexting, their chatting, but when it actually comes to facing her, he's been avoiding it. And he was very upset about it, and he wanted to deal with it. Not just avoiding it, he also said, but that's not my only problem. So when he told me he was avoiding it, I thought, okay, performance anxiety, straightforward. I know how to deal with you. And I started my chat, and he said, no, doctor, that's not the only problem. I'm extremely tired. I have no energy to do anything. I have a lot of other problems. So he gave me about 20 problems that I couldn't connect up, very, very non-specific symptoms. And then when I was thinking, what could be linked up, how many blood tests should I do? He actually gave me the answer himself. He gave me his diagnosis. He knew his diagnosis. And his diagnosis was Dhatu Dosh. And the reason I put the name down in Hindi and not in English is because actually there is no equivalent that we know about in the English language. So it's very specific, and you have to be Asian to really understand this. So what is Dhatu Dosh? It does have an English name. It's called the Dhat syndrome. So if you read unusual and rare psychological disorders, it comes under Dhat syndrome. It's a culture-bound sexual neurosis. And what it is men associate semen loss. So when they lost semen either by masturbation, nocturnal emission, or even sex, they feel there is a loss of energy. 1 drop of semen is 100 drops of blood. And if your Dhat syndrome is really bad, 1 drop of semen is 1,000 drops of blood. And that's how they equate it. So you can imagine how much blood they've lost after having a bit of sex. And it's associated with anxiety and depression. So a lot of these patients report that they actually have anxiety and depression, not specifically related to it, but even as an underlying problem. And symptoms there is a whole constellation of symptoms, but that may include fatigue, low sexual interest, poor sexual performance like erectile dysfunction and premature ejaculation, low mood, and catastrophizing. Nothing in my life is going to be again. Everything is just terrible. These are the people who sit like that, and to get them to look up and look at you in the face is difficult. And it's not just Southeast Asia. So we used to think it's a kind of an, India, Pakistan, Bangladesh, Sri Lanka problem, but not really. Apparently in China, again, they have an equivalent syndrome. And not just Southeast Asia, apparently it was quite common in Europe as well. And somehow since the 1960s, it seems to have become rarer and rarer and rarer. And I wonder why. And I think we kind of know why. And it's not just men. Women also complain of these symptoms, and they say it's associated with loss of vaginal discharge. I have so much vaginal discharge, doctor, that I have no energy to do anything at all. And I think that is a female equivalent of a Dhat syndrome. So what has caused it? And it's very easy because I said, oh, well, we give it an Indian name. So we think, oh, it's a cultural belief unique to us. And it's because we have such a negative attitude to sexuality, but actually it's not just an Indian syndrome. Where did this anti-masturbation, anti-semen loss campaign come from? And I think it was called onanism, and that was from the 1700s. And this was a doctor, a very famous doctor called Dr. Tissot, who published a medical textbook called Diseases Caused by Masturbation. And this was a medical textbook in circulation up until the 1950s. So that cultural belief doesn't just seem to have come from the culture, it seems to have come from the medical community, who seems to have sort of taken that on and decided, okay, this is a problem. Freud had a bit of his theories as well. Sigmund Freud, I think he did his own contribution to this. And in the Victorian times, in the 1850s, they developed this 4-point ring. It's got a ribbon at the end, and you can imagine all the young men go to sleep with that tied around the penis. So if you ever get a hard one in the night, and if you ever masturbate, that's going to poke you. So that was to prevent masturbation. And it was as bad as that. And somehow that practices with the sexual revolution seems to have disappeared in the West. And that may be the reason why we don't see so much dark syndrome. And so it's kind of important to remember that our cultural beliefs may be caused by some of us, in fact. So what did we do for Mr. A? How did we treat his problems? He wasn't that easy to treat. He'd lived with his problems since he was 23 or whatever. Not just that, when he masturbated, his object of his fantasy was clearly the woman he loved, or when in his teens. And then he felt really guilty about it because she was somebody else's wife, and that's not how he wanted to think about her. So there was this very deep ingrained guilt and quite a lot of associations with what he was doing. So he needed psychoeducation to say, yes, it's okay, it's absolutely fine, whatever you've been doing, you haven't lost your energy. But he also needed cognitive behavioral therapy, because every time he wanted to think about sex, he needed to think about things. A lot of other things seems to come and cloud his mind, and we had to untangle it. So he went through several sessions with my clinical psychologist. I also gave him a PDE-5I, which is sildenafil is what I started him on, because when he started having performance anxiety, I just needed to make sure that when he was ready to have sex with his partner, he was able to. If he lost his erection again, that will take him back several steps in losing confidence. In fact, later on from sildenafil, I converted him to tadalafil to put back the spontaneity. 3 months later, he actually stopped all treatment. He slowly came off it, went back to on demand, and then he stopped when he felt he could manage it by himself. We included his wife every step of the way. Remember, when you're treating patients, you need to get your partner in. If you have a wife who's not in your room, but she doesn't want to have sex with him, we shouldn't be working with them as sex therapists. So we just need to make absolutely sure that the couple are both involved in whatever we're doing with them. So that's Mr. A. On to Miss B, Dr. B. She's a doctor. She is a PhD doctor, not a medical doctor. Very highly educated, beautiful woman. She's a 28-year-old academic. She was very well educated about sex. Her sexual knowledge, I couldn't fault her. Every time I kind of tried to pick out some kind of misunderstandings or myths, she actually seemed to be very aware of her own body and what to do. She masturbates 3 or 4 times a month, and we had an interesting chat about her PhD and how stressful it is to finish a PhD. And she said, you know what, actually, sometimes, that the masturbation actually helped relieve the stress. She's recently been sexually active. This is a person she's known for some time, and then they got married. She wanted to get married before they had sex. They were each other's first lifetime partners. So she finished her PhD, got married to the man, and first time they're both having sex with another person. And they were both very happy with each other. She wanted to be with him. And what she found was she can orgasm when she masturbated, which she could always do, but not with her husband, not with this man that she was with. When he had sex, she couldn't orgasm. She was a little bit worried about whether she masturbated a bit too much or whether there was a problem. And I wanted to see them together as a couple. On further history, it turns out that he was a lovely young man, very, very willing to be led by her, very willing to be taught by her. But his sexual ideas and education was actually much lower than hers. So his idea of sex was to get into bed, have an erection, have a penetration, and finish very quickly. And no wonder she never orgasmed. So we needed to educate him. So his management, that's the female sexual response cycle. We had to tell him about how women can feel neutral about sex. When they're given a sexual stimulus, they can feel aroused. The arousal can lead them to cause more desire. And if they had very good sex and they were emotionally and physically satisfied, they will want more sex, and that's likely to help them orgasm better. So both of them needed couple psychoeducation. And we actually used masturbation as part of the couple therapy. So we knew that she could orgasm with masturbation. So we said, why don't you help her do that? So the couple did it to each other, and then they did it together. And then they moved on to have a very satisfactory sexual life. So for this couple, what they needed was specific suggestions, specific therapeutic suggestions on how they can manage their sexual functioning. And again, very, very good outcome. That takes me on to masturbation, because when we talk about myths and misconceptions, masturbation is a big one. It keeps coming up again and again and again. And also when I treat patients, that's something that keeps coming up. Is it good? Is it bad? And interestingly, with pornography coming in and all the really difficult, different kind of pornography to what we were used to in our younger days, this is becoming a problem. So that's why it's again in the news again. Masturbation on the whole can be positive. It's an expression of sexuality. Most of us are aware of our sexuality in our early teens. And the time we are sexually active is much later. And that's not necessarily a bad thing. So, we don't want to start having sex the minute we are aware of sexuality. But then how do we express our sexuality? How do we know ourselves? How do we know what makes us happy or not? So you can't go for 30 years without knowing anything about sex, not even knowing what parts lie down, under your underwear, and suddenly turn on a switch and start to have sex on the first night. And that can be a very difficult thing for couples. So masturbation can be an expression of sexuality. It can complement partnered sex. And I often tell couples that you need a menu. You can't eat the same thing again and again, not the same rice and dal again. Have your starter, have your main meal, have your dessert, put your variety, and you're never going to enjoy it otherwise. And this comes in as a very important part of partnered sex. It enables greater sexual satisfaction. So there's quite a few studies on sexuality and masturbation, both in men and women. And women, particularly women who masturbate or seem to have a higher sexual knowledge, and they're more able to enjoy partnered sex. So that can have a hugely positive effect. We use it quite a lot in sex therapy. So I told you about one couple where we used it. Another very common one that we see is premature ejaculation. I'm sure working in the subcontinent, many of you have seen many cases of these. Start-stop technique is something we often use. So where a man starts masturbating to the point of ejaculation, stops, and then starts again to extend the ejaculatory time. And that is a masturbatory technique, really, in a sense. And then, of course, there are possibly other things that we don't know in terms of benefit. The thing that comes in very frequently is prostate cancer risk. Apparently, men who ejaculate 3 times a week through masturbation or sex decrease their prostate cancer risk. The evidence is not very strong. Don't quote me on that, but there is potentially other benefits to masturbation. Can there be risk? Yes, everything in life can be risky. You can't wake up your eyes and open, you can't wake up in the morning, open your eyes without a risk of dying that day. And that is the reality in life. So anything can be risky, and masturbation is one of those. For the majority who masturbate, a minority have a problem. So 2 things we see. One is dysfunctional or idiosyncratic masturbation. So people see a particular kind of porn, see a particular kind of stimulus, masturbate in a particular situation, especially difficult when they don't have privacy and various things, and then they find it difficult to perform during sex. So both men and women have this problem. Men can get an ejaculation, women get anorgasmia, and actually it's a relatively easy problem to treat. The second thing to remember is the refractory period. So when a man has an erection, it takes him a few hours to get all the mitochondria back in action to get again. And when they're younger, the refractory period can be very small. And I know my young men who come and say, I don't know what you're talking about. I can get up 2 times in the night and do it. But most men, as we get older, men's refractory period gets longer and longer and longer. So once a man has an erection, he needs a bit of a rest for some time. So if you're going to masturbate excessively and then try and have sex with a partner, that is going to become a problem. And so when you take a history, it's really important to find out when and how they're masturbating. So on that note, I'll move on to my next case, Mr. and Mrs. C, who are a very lovely couple. I saw them about, must be 8 or 10 years ago now, but I often think about them because it's just one of those nice patients that you remember. They were in their late 40s and he was in his early 50s. They'd been married for 25 years. And she read about sex in a women's magazine and really wanted to come and talk to a doctor, a woman and an Asian, so that she can actually express her problems. So they live in London and they are an Asian couple, and she preferred to talk to a woman about it. So she read about sex in a women's magazine, and she realized that she'd never had an orgasm. And maybe she doesn't have enough desire either, because she said, he always initiates when we thought about it. And I don't know why that is. That's how it's been. Maybe I've always had a low libido. I don't know. And she told him about it, and he's getting worried now. He said, oh, maybe it's something wrong that I'm doing. Maybe I'm not doing sex the right way. We don't know what to do. We better find out. So the couple came to me to answer their questions. And I asked them a few more questions. So you can never take it on face value and make a diagnosis. They have sex once or twice a week. Sex is very enjoyable and they're very satisfied with sex. They look forward to having sex. Considering that she's getting very close to menopause, she doesn't seem to have any dryness or menopausal problems. He doesn't have any problems with his erection. So they seem to be okay in that department. And then I also realized that she gets clitoral orgasms, and which are absolutely fine. So normally start off and he gives her some stimulus and she gets an orgasm, and then they have sex, but she can never have a vaginal orgasm. And that was the problem. So when she said she has no orgasms, what she meant was she can't get vaginal orgasms. And that's something to remember, that all women, almost all women, can have clitoral orgasms, but a proportion of women, between 20 and 40%, depending on the study, don't have vaginal orgasms. So no matter what we do, no matter what we put in, for some women who don't have vaginal orgasms, they just won't experience it. It doesn't mean that they're having poor sexuality. It doesn't mean that they're getting immature orgasms, because Freud believed that vaginal orgasms were the real orgasms. And I think it comes from a male model where they think if you did something without the help of a man, it can't be good enough, surely. And that's not true. So women who have clitoral orgasms have very satisfied sex life. They can have a vaginal penetrative sex. They can enjoy that as well, but that's just the way it is. And that is okay. That's the varieties of sexuality that we enjoy. And this couple have tried various positions. They've tried various toys, and she can't have a vaginal orgasm. So for them, all I needed to do was limited information. You're a very happy couple. You're doing everything right. You're better than most couples I meet. Just go home and enjoy life as it is. And that doesn't seem to be a problem. So on to my next patient. This is a modern Indian couple. And I think, my generation thought we were the most modern and young and great. And the next generation are even smarter than us. How can it be? So this is Mr. D and Miss E. Very young couple. They met, they got their parents' approval, they got married. They didn't want to have sex. I mean, they wanted to have sex, but they didn't want to have children. They wanted to wait for a few years before they had children. They wanted to establish their careers. They wanted to travel. They wanted to do lots of exciting things before they do settle down and have a family. So they didn't like using condoms. So early on, they started having anal sex because they just thought that's one way to avoid it. Now she's on the contraceptive pill, and they both have vaginal sex as well. They both enjoy it, but they also have a bit of anal sex because that's how they started it. That's how they enjoy it. And they wonder whether, they think that's okay. But recently they read somewhere that anal sex increases the risk of infections. And suddenly they're worried about infections. And they're also, because they want to have children eventually, and she doesn't want to end up with an infection that stops her having children. And secondly, they're also kind of a bit shamed about it. Are we doing the right thing? Are we doing something terribly wrong and horrible? And for this couple, I had to talk about anal sex and infections. Yes, anal sex increases the risk of sexually transmitted infections. So it's a common kind of sex for men who have sex with men. So that's the penis inside the rectum, and that causes more trauma in the rectal mucosa. And if there's trauma in the rectal mucosa, if there is an infection, the risk of transmission increases. So both hepatitis C and HIV, we see increased risk of transmission. But that does not apply to this heterosexual monogamous couple. They don't have a sexual infection to start off with to spread between each other. So sometimes I say, if you find it uncomfortable, you can always use a condom for anal sex and not for vaginal, or the other way around, if you think you'd like it, but actually it doesn't really matter. A lot of heterosexual couples have anal sex, but very few actually talk to their doctors about it. So where I do sexually transmitted infections. We take a sexual history in all our patients. And what we found is face-to-face with doctors, 50% did not disclose that they were having anal sex, but they would to a computer. So if it's an anonymous questionnaire, they will say yes, but to a doctor, they'll say no, because they're worried that I will think that it's a shameful thing to do. So this couple, all they needed was permission to just go on and enjoy their sex life as they think is normal. So now I'll come back to my quiz that I started. First question, frequent male masturbation leads to loss of energy. True or false? My answer is false most of the time, but not all the time. It can sometimes be true. So don't say false or true. It's somewhere in between is the answer. Next question. Women who masturbate may lose the ability to enjoy pleasure from normal sex. False most of the time, true sometimes. Sometimes if they have an idiosyncratic masturbatory technique, that could affect their ability to enjoy normal sex. Vaginal orgasms are better than clitoral orgasms. Again, false most of the time, but there are studies where women who can have both kinds of orgasms find that they like their vaginal orgasms better. So it's not always false, but sometimes it is false. Anal sex increases the risk of infection. True most of the time, but not always. So when you think about sexuality, remember that there are more than 50 shades of gray. There are no true or false answers. It depends on the couple. It depends on what they're doing and what the answer is. And that takes me on to my final slide. Can myths have a role in life? So far we said myths are all related to misconceptions. It's all terrible. It's all bad. But actually, can it be good? It could have a cultural value. And you have to be particularly conscious if you don't understand a particular culture. And you know, in countries like ours with big populations, there are microcultures. What one set of people do within their cultures is different to another. It may have a cultural value, and we have to ask more questions to understand it. There may be a utility to why they have those particular myths, and there may be a reason why those myths have evolved, and it's worth thinking about it. It could be a mode of expression. So I remember one couple where they were meeting once or twice a month. They lived in 2 different places because of work. And whenever he came over, there was increased pressure to have sex because she was desperate to have children. And he had to have sex too, you know, several times that weekend packed together. It's very hard for a man to tell a woman, look, I love you and all that, but I can't have sex so many times. It's much easier to say, look, I've got to work on Monday, and actually, you know, I don't want to lose all my energy. So, you know, can we just limit it? And she'll be very understanding. She'll say, oh, of course, let's save your energy on a Sunday evening. You can have a rest. And so it could be a mode of expression for things we cannot communicate. And finally, myths can hold beauty and symbolism. When we talk about sex, let's not get all medical. This particular picture is a beautiful piece of art called Union by the artist Aparajita Baraj. She does a whole series on myths and how beautiful can be. And remember, sex is what makes the birds sing. Sex is what makes the heart dance. And just like sex, our myths can hold beauty and symbolism. So listen to our patients. Remember, they are the experts. On that note, I will finish. Thank you.
Sir, could you please unmute yourself, sir? I think you're on mute, sir.
Yes.
Thank you.
Dr. Shamsul Hassan, please start your presentation on paraphilias affecting sexual life.
So is it being seen?
Yes, make it PowerPoint. Good.
Oh, yes. So can you see the slides? So my slides are there. Can it be seen?
Yes, sir. Yes, sir.
Okay. So I was fascinated. I was seeing Indu Shalini, how wonderfully she was presenting her topic. And it was wonderful. And she carried out all the journey. So for many of us, it would be a bit difficult to grasp the content of the paraphilia. So I am Muhammad Shamsul Hassan. Professor Venkataramanan sir has addressed me, and I think it was a bit exaggerated. There are a lot of people who were doing sexuality in Bangladesh as well. So I'm too young for them. The paraphilia, the topic itself creates a lot of confusion, because what is normal and what is abnormal, it is still on debate. So we'll just touch upon the topic and we'll just move forward. The paraphilia, the term itself comes from the Greek root, where they say the para means beside and philia means love or friendship. So it means beyond the normal friendship. When we talk about sex, we think about sex, we consider sex is between a man and a woman, or sometimes between a man and man, or women and a lady with a lady. So apart from this dichotomous feeling, there are some other sexual preferences where a person may have sexuality, sexual attraction, their arousability to somewhat different topic, somehow which is not sexually attractive, somewhat which is inanimate. So that is all about paraphilia. So before we go into the detail, we'll just tell that paraphilia earlier was considered as a perversion, but over the years it has been incorporated as a specific form of disorder. And in Diagnostic and Statistical Manual, which is the psychiatric classification according to North America, US and Canada, so they have considered that out of 106 different categories of paraphilia, there are 8 paraphilias which are of very important, which has got impact. So I will just touch upon these topics and I will just talk about how we treat them. So before I go into the detail of paraphilia, I just want to take a brief journey about how we classify sexual dysfunction. Earlier, it was defined as sexual dysfunction was defined in basically 4 different planes. One is the disorder of the human sexual response cycle, how a man gets aroused, how he has got the desire, and how he has got the ejaculation. And also the other way around, how a lady gets attraction to a boy, how she gets her arousal and then orgasm. So whatever sort of disorder incorporated with the human sexual response cycle, we consider it as a disorder of human sexual response cycle, like in case of men, premature ejaculation, erectile dysfunction, low sexual desire. In case of women, vaginismus and so on, dyspareunia and low desire. And also we used to consider that the orientation problem was a disorder, like a man can be attracted to a girl, or a man can be attracted to his own, with a man, or a lady can be attracted to a lady. So this orientation, how he becomes attracted, whether it's a boy or a girl, we used to call it as a sexual orientation. Earlier it was said that homosexuality, lesbianism or bisexual. And also when a guy was born like a guy, but he feels like he has been entrapped. He thinks he was being trapped in a wrong gender. Like a boy was reared up as a boy, but he thinks that his gender, which was biologically assigned, was not right. He thought that he was trapped. So that we used to call gender dysphoria. So this orientation problem, like homosexuality and lesbian, and also the gender dysphoria is no more considered as disorder. So these 2 are omitted. Last but not the least is the abnormal sexual preference. We call it paraphilia, which is basically, I said that a guy can be attracted to a person who doesn't have a consenting age. Let's suppose it's a prepubescent or pubescent boy or girl, or something he gets arousal with some inanimate objects, non-living things. So these are the paraphilia we say. So according to the psychiatric classification, how do we define? It is the intense and persistent sexual interest away from the normal sexuality. Mark the 2 words, that is the intense and persistent. And also it is any sexual interest which is greater than usual. And he has to have a significant impact. So there are 2 different kind of emphasis has been given. One is the qualitative and another is the quantitative. Qualitative means the person has got the attraction towards a boy who doesn't have a consenting age, or a girl who doesn't have a consenting age. So he may not have that much of sexual interest, but still they are doing sexual intercourse with the prepubescent child. And another thing may be the person may be get aroused with getting an excessive urge. He may have the attraction towards the other, the inanimate objects. So that is the quantitative aspect, and the person is being distressed. And another form of telling is he has got an excessive amount of sexuality in the form of masturbation, in the form of watching porn, or in the form of doing some other objects, but he is also getting distressed about the fact. So we call it sometimes hypersexuality, sexual addiction, or compulsive sexuality. these two different things are both the qualitative and quantitative phenomena are incorporated as paraphilia. So there are a lot of discrepancy. How much is too much? When we call the hypersexuality as a hypersexuality, when we call watching porn is something paraphilia, watching getting someone having sex, we get sexually aroused, is something paraphilia. So sometimes all human beings can have this sort of experience, and when to call it a disorder. So that is the problem. And another important issue is hands-on and hands-off phenomena. Not all paraphilic phenomena can be considered as a problem. Someone has may have a fantasy about sexuality. He may have think of some child. He may have think of some other ladies. But since it's not violating other people's privacy, we cannot put him under jurisdiction. Suppose a guy is masturbating thinking of a small child, and he never touched a small child. He never violated other people's privacy. We cannot hold them responsible for breaking laws. But there are other people who are frequently touching other prepubescent child, and they do some behavior which is strictly punishable in the law of the land. So there are two things. One is the qualitative and quantitative phenomena, and another is the hands-on and hands-off phenomena. Hands-off, we say when our fantasy is only limited to certain aspect, but don't violate the norms. Our hands-on is when the person has got compulsive sexuality and he breaks the law, he rapes others, he touches other people, and being the perpetrator and being sent to prison. So these are the two things we have to consider. Just to clear the issue, how do we see these clients? Just giving an example. Few months back, a doctor was brought to my office with his wife. She is also a doctor. He was an eye residency. He is an ophthalmology resident who is very polite, who is with his friends and with his colleagues. But he was accused of touching the private part of a small girl while he was doing sleep exam. So the authority, it was reported to the authority, and he was fired. Though he denied the complaint, but still authority has got previous charges, accusation against him. So they thought that it is just a continuation. When I interviewed him in separately, he said he doesn't have a proper attraction to his wife. His wife apparently is very lovely, very sweet in her appearance and everything. Nothing was wrong, but he doesn't get that sort of appetite for his wife. But whenever he sees a prepubescent child, the doctor, he gets aroused, and he is very much ashamed. And at one point, he wanted to commit suicide because, as a doctor, he feels that this behavior, this compulsive act, has ashamed him, humiliated him, and it was being notified to other people around, and people see him as a very bad guy in the society. So that is the hands-off problem of this doctor who knows everything, but he could not help himself. Another 42-year-old banker came to me, and he was married for 15 long years. His wife was on the verge of divorce because the wife suddenly found out that the guy was about to have an intercourse with the some domestic help. So when they were about to divorce, and the lady, his wife, knew that this guy was otherwise very caring, but this habit is there. So he said, I want to give it a try, whether if it is treatable, we'll treat, or otherwise I will get separation. And also the guy and the wife said on separate interview that this guy has got erectile dysfunction. He could not perform sex with his wife. But at the same time, she was wondering how this guy is attracted to some other children when he cannot satisfy me. What is wrong with me? Am I not being satisfying him properly? So the guy in separate interview said that he doesn't have any attraction with his wife. He takes some tadalafil and do sex with thinking of some other girls, small children. And this is how he's managing his life for the last 15 years. And I work in a medical university, and frequently we get some, prison referrals where people were held in the prison just because they have raped either serial rapist or have done some sexual offender. So these three are the cases how we see our clients. Some people breaks the law, are being sent to the prison. Some people are still managing, but they have some problem. So like I said, that there are 8 different type of paraphilia which are being classified in the psychiatric psychiatric classification. One is the pedophile, when you have got the attraction towards children. The next is the sexual sadism, when you have got you inflict humiliation and bondage or suffering to your partner. And when there is a sexual masochism, when you undergo humiliation, bondage or suffering. And there is a voyeuristic disorder, spying on others, and you get aroused. Exhibitionist, when you expose your genital, you get aroused. Frotteuristic, when touching or rubbing against a non-consenting partner. And fetish, when wearing non-living objects, having highly specific purpose. And transvestic, when you engage in sexually cross-dressing. And this transvestic, they get arousal just to get sexual attraction. But there are other people who get, he does the cross-dressing just to feel that they belong to the opposite gender. That is a gender identity problem. So why people are behaving so differently? Why people have got so much of these problems? And it is multifactorial, yet to identify a lot of the causes. So one may be the prenatal androgen exposure, when the child was inside his mother's womb. If the mother is somewhat taking some androgen, that can lead more risk. It is said that the perpetrator, those who are pedophiles, they themselves were being the victim of childhood sexual abuse. So, and somehow it is being shaped in their mind. Also some head injury, low IQ, short stature, these are related with pedophiles. And in the MRI, there are decreased volume of the amygdala in the brain. In the brain, you can see the size of the certain brain areas, the amygdala and hypothalamus are reduced. And also, it may be due to the influence of serotonin and dopamine, because serotonin is responsible for your brain sexual compulsive act to get reduced. So when there is a lack of serotonin, your excitation goes up. And also, if there is a high dopamine, it will have more excitation. Especially if you see that some Parkinson's patients are taking dopamine, syndopa carbidopa, their sexual excitation goes high, their arousal, their desire goes high. They attempt sex, but they cannot perform due to their old age. And fetish I have described, I'm not going to the detail. And if you want to classify someone as fetish, it has to be for 6 months. And he has to have a significant distress. And also in case of sadism, there should be intense feeling of sexual excitement when fantasizing about or witnessing another individual undergoing physical and psychological pain. There should be at least significant distress. And like I said, that the masochistic disorder has to inflict, humiliation, torture upon themselves, and they are distressed about it. So how common is this? There was a study in USA. They have seen that among the 400 females they have interviewed, 24% of them had got sex with their male partner who were at least 5 years older than them. So that is one criteria when we say pedophile, because if we want to label someone as pedophile, they have to, even if they are non-consent age. Let's suppose the perpetrator himself is less than 18. The difference between the perpetrator and the victim, the person who is having sex with the guy, has to be at least 5 years difference. So then we call it paraphilia as well. In this study, what we have seen, those female, 4,000 female, it's a large sample. Of them, 24% have sex with guy at their age of 14 or less, with men who has got age 5 years older, that is 19 or above. And also recidivism is there. Those who don't know, recidivism means doing the same crime again and again. So it's very common among the paraphilia to do the same crime. It is associated with other disorder as well, like a major depression, bipolar, and so on, dysthymia, generalized anxiety disorder, and panic disorder, ADHD. And what is the cost and the impact? In a study in US, they have seen that the pedophiles, the paraphilia and the sexual violence causes $450 billion per annum. So it's a huge cost being inflicted in the US. And is it only a male phenomena? In a recent study, Pierre Bricken and his colleague has seen that it is not only happening among male, it is also common in female. There are a lot of women who have expressed their pedophile, they have watched porn, they have gone to the sites, they cruise around the sites, which is about the children of prepubescent or pubescent age. So it is also common among women, but not as common as among men. How do we assess? We have to take the clinical interview, have to take a proper sexual history. We have to see the paraphilic behavior, formal testing. I just want to put some emphasis on the penile plethysmography. That is that determine the sexual interest by measuring the penile tumescence. You show her some pictures, you see her some videos, and if you show him, if you measure the penile girth, and if you see there's an irritation, and you can see that he may have an attraction towards the small children or other inanimate objects. So that is one way you can see. So how do we treat them? As we said that there are a lot of pedophiles which is of diverse origin. So the problem is heterogeneous, and we need an integrative treatment because we give psychotherapy, we give hormonal therapy, and we give other treatment as well. The main mainstay of treatment is psychotherapy, pharmacotherapy, and the androgen deprivation. Androgen deprivation is specific for those who have got compulsive sexuality, who breaks the law and causes trouble in the society. So it depends on the law of the land, how the society sees them and how they want to treat them. Before treating them, we need to see their medical history, compliance, whether their paraphilic sexual intensity, how frequently and how intensively it comes, whether they breaks the norm, which is hands-on phenomena, they cannot resist the temptation, and so on. Our main way of treating them is to give, control the paraphilic fantasies, control the repeated crime, and also reduce the level of distress. Like I said, paraphilia will be always considered as a disorder when the situation has a significant distress among the clients. They have got a problem and also they are distressed about it. So psychotherapy, the gold standard is a cognitive behavior therapy. You can give it individually, you can give it group therapy, and maybe even in combined. You can give it in your clinical setting, in your hospital. You can give it in the prison cell as well. So it depends on the design. So mostly what we do in CBT, cognitive behavior therapy, we try to change the way people think. This paraphilic have got some irrational thoughts. Sometimes they express that we do sex with the children because we need to teach them how to have a proper sex. And they justify their irrational thoughts. So CBT's main goal is to change the way they think. And there are certain other behavior techniques where you condition the person. When they have got a paraphilic fantasy, you give a olfactory, very odd stimulus. And the next time he think of the paraphilic fantasy, he have the smell of the, you will recall the smell. So, and this is the covert sensitization as well you can do. So when we give the pharmacotherapy, especially it is of juvenile paraphilia, when there is a comorbid obsessive compulsive disorder and depression, we give SSRI. It is an antidepressant like sertraline, paroxetine, duloxetine, sertraline, citalopram, fluvoxamine, there are so on. So especially when there is a less intensity problem. And also we give androgen, acetylcholine and progesterone. We only provide when there is a compulsivity, when they are breaking the laws and so on. And also recently the GnRH, gonadotropin releasing hormone is being given. LHRH, luteinizing hormone releasing hormone are given. These are basically the chemical castration. When compulsive sexuality reaches a point when you need to reduce their sexual desire, These are the good drugs. The top of cyproterone acetate, the better is GnRH because it's a long-acting drug, and you can give it, and it gives a sustained anti-androgen effect. And also in sexual offender, LHRH is a very good treatment, and it shows a significant improvement among the clients. And also, if last but not the least, if nothing helps them, you can give for castration. But keep it in mind, even if you castrate the patient, 1/3 of them can develop the recidivism. They do the same time again. So also there's an ethical issue. The country you are practicing, your practice has to be approved by the law. Like in Bangladesh, we don't have a specific rule about paraphilia. But whenever you are treating the children, whenever someone is violating the social norms and torturing the children, it is strictly punishable. They consider it as a criminal justice is being provided to them. They are brought to justice. And how long we treat? For mild paraphilia, we treat about, let's say, 2 years. For severe paraphilia, you have to give 3 to 5 years. But keep it in mind, whenever you give androgen, their sexual recurring thoughts, the desire will go away. The paraphilic thought will never go away. The only hormones and androgens will reduce the desire, reduce the erection. The paraphilic, for your paraphilic thoughts, you have to give psychotherapy because it's programmed in the brain. So if we just sum up in the algorithm, psychotherapy should be given for all clients and all paraphilic offenders. It is mild, moderate, severe, no matter. SSRI can be given when the mild cases, they don't get treatment and they don't get help only with psychotherapy. You have to give SSRI. And if there is associated obsessive compulsive disorder, you have to give SSRI. And when we give medroxyprogesterone and cyproterone acetate, when there is hands-on phenomena without penetration, they touch the private part, other part, vagina and breast, but without touching the, without intercourse. So we give SSRI and low dose of cyproterone acetate. And if the above regime doesn't help, and there is a moderate or high risk of sexual violence, in severe paraphilia, we give psychotherapy, SSRI, and injectable cyproterone acetate. If it doesn't help, and there's a severe violation, sexual violation, severe paraphilia, we have to give GnRH, long-acting. And we can use the triptorelin, diprolite, and other drugs. And if above all measures doesn't help, in most severe paraphilia, we have to give anti-androgen, long-acting GnRH, and SSRI. So this is the algorithm. And you keep it in mind that all paraphilia, whatever may be their cause, must have some sexual dysfunction. And they will be visiting you one or the other from. Either they will be coming to you by themselves or their partner, or by the the jurisdiction, by the law enforcing agencies. So that's my presentation. Thank you all. And if any query, I'll be there to present.
Sir, could you please unmute your mic, sir?
Oh, yes.
So it is a very big problem in India, and we are dealing with an act called the POCSO Act, Prevention of Sexual Offences Against Children. This we are going to deal in detail by next Saturday. We are conducting 2 more webinars in the next week. One is on Saturday and one is Monday. Saturday, we are doing with domestic violence and all the rape things. On Monday, we are dealing with andropause, purely testosterone. So on Saturday, we can get a lot of information regarding this pedophilia. Now it is my turn. After the 2 luminaries, now I am feeling hands and feet are shaking to talk to you people. Let me try my best. My slides are not moving. So now, yes, now myths and misconceptions, paraphilias are covered. Dysfunctions, the last webinar we covered. So whatever is left over is, yeah, just touch upon the orientation issues. Dr. Shamshul has touched upon this. Gender identity issues is touched upon. Adjustment problems has to be dealt in detail. So all these things I'll just touch upon. Though sexual orientation, though it is not there in the DSM-5, previously it was there, many clinicians, many healthcare practitioners are tuned for this orientation problems. When a child is born, looking at the genitalia, the parents, the relatives are giving them, yes, male boy, female girl. Like that, they are assigning their gender. And they are rearing them in the same way. If the male boy is there putting a male dress, telling him, you are a male, be brave, should not, when he falls and cries, should not cry, you are a male. So in that way, we are rearing them. We are giving identity for that. And when they are growing up, they will express their gender in the masculine way. You have to do exercise, you have to eat, grow your muscles, you should be like this. So a prototype will go. When they are in the youth, they will get, depending upon the attraction, if they are attracted to the opposite sex, called heterosexual. If they are attracted to the same sex, called homosexual. This thing is going on. So this orientation can be heterosexual, homosexual, bisexual, queer, or of late we are getting a group called asexual. They don't have any experience, any attraction towards anybody. This is of late phenomena. So now the youth is in the crossroads where to go in the sexual orientation issues. Now, as I told you, even Shamshul has touched upon this. DSM-5 that came into existence in May 2013 has clearly said orientation, gender identities now is a normal phenomenon, a variant of normal phenomena that is replaced by LGBTQ, that is lesbian, gay, bisexual, transsexual queers, and gender dysphoria. All this is now called, this is a pattern. This LGBTQ is commonly called as sexual minorities. They are fighting for their own rights, their own legal issues. In every country it is going on, including India also. If you look into the prevalences of these LGBTQ special sexual minorities, around 3% of 2.9% of men and 2.2% of women in the world are suffering with this orientation issues, LGBTQ issues. I don't want to go in detail about it because it is itself a big subject. We have to do one separate seminar on this. If you look at Indian statistics, we do census every country will do in the same way. For every 10 years, we'll be taking census. Next year is our census year. So if you look at the census of 2011, the Indian census clearly showing 4,90,000 people, individuals, they claimed as third gender. They are claimed as LGBTQ in India. That is the first time. Prior to that, in 2001 census, nobody, no third gender. In 2011, it came out 4,90,000. This speaks there is a huge number of people are there who are practicing in the LGBTQ called sexual minorities. So this is the Indian picture showing the prevalence rates in all the respective states here. And the homosexuality is recognized and legalized in many countries, is no more existing, is they have formed into the mainstream of life. We, even in India also, way back in the September 2018, the apex court, Supreme Court has given a judgment saying that it has to be decriminalized. It is no more an offense, homosexuality. Since then, they are mingled in the mainstream as a normal variant population. And one thing why I'm driving all these things here is, as a healthcare provider, whenever you are getting a case of a non-consummation of marriage or couple coming to you with sexual dysfunctions, please inquire about the sexual orientation. I am practicing for the last 34 years as a sexology. In the initial years, I did a mistake. I learned from my mistake. Because once way back somewhere in 89 or 90, when the couple came, bought by their parents, respective parents, saying that, doctor, we have performed marriage, this fellow is not doing anything, please check whether, give certificate whether he is a fit or unfit. After taking history, he says, yes, I am getting erection, I am masturbating, everything okay. Then on physical examination, everything is normal, investigations normal. Then I am at the crossroads where to put the diagnosis. I utterly failed to inquire about sexual orientation. He is oriented toward the same sexual person. That's why he is not consummating the marriage with the wife. He has forced to enter marriage with the wife because of the family social reasons. So hence, my friends, always inquire about sexual orientation while you are taking sexual history or when you are evaluating a person with this type of problems. So don't forget, that's what I am telling, asked about the non-orientation. A little bit about gender identity issue. This is nothing but the person who has got the gender identity by their parents and relatives saying that you are a boy, but that person is not comfortable in the role of a boy. Now it's called gender dysphoria, which is a nothing but discomfort in the sexual relevant physical characteristics of one's assigned gender. This gender dysphoria can occur at two stages in the life, different life stages like childhood and adolescence. Our concern here is always remember that sexual dysfunctions, myths and misconceptions, and adjustment problems will be there in the gender dysphoric people and LGBTQ people also. That much information we should keep in mind so that while evaluating these type of sexual minorities, we can do justice to them. So the pride, the famous third gender in India is Shabnam Wasi. She is the first third gender person elected to the legislative and even to the parliament also from Madhya Pradesh. The next one's first Swapna, the first trans personal to clear Tamil Nadu State Public Service Commission to enter into the government job. And the first transgender news anchor Padmini Prakash. Like this, we have many people who are entering to the mainstream and occupying many good positions in the administration. Then coming to the adjustment problems, good number of reasons are there why the couple are unable to adjust in their problems. As I told you, for the last 34 years, after interviewing, after examining so many couples, individuals, I could see some rare reasons for their adjustment problem. I am focusing and presenting to you. So these are all the common complaints made by the men against the woman. The commonest complaint in the majority people what I got was, doctor, she is always cold, dumb, non-responsive. Whenever I approach her, she is cold, non-responsive. This is the commonest complaint made by the boys or the women, boys or men. Then we have to examine them, we have to educate them, and we have to tell and we have to counsel them. We have to talk to the wife and try to encourage him, try to appreciate his advances, try to, because it is a play to be played by the both the people. Unless you play your role, the sex will not be that beautiful what you are thinking. So we have to educate her. Be open to discuss about these likes and dislikes. Both can participate and enjoy. If you are unable to do it, approach a healthcare provider so that they will do justice for you. That's how this problem has to be solved. Try to ignite his desire, making bedroom more lovely, and try to dress up yourself more romantically, and try to respond to his adventures so that you will become more responsive and he will get more mood and both will enjoy. The next common complaint made by the males is, doctor, she is nagging for everything. I won't feel like getting more. So this nagging in the bedroom is again a nasty thing that's spoiling the show. So we have to educate them, never discuss about money, in-laws problems, his inactions. Huh? Don't discuss in the bedroom. That is not the time, that is not the place to discuss. You have to discuss them, discuss in gentle way, amicable way after sex, so that both of you will be enjoying the sex. That point of sex education is more than sufficient to solve this problem. Another common complaint that is posed by the men is, doctor, she is demanding, not sensitive. This is another way where males are feeling. So never, we have to educate the couple and particularly the woman. Never discourage our partners by commenting about their organ or performance. Try to encourage him. If you are unable to encourage him, try to meet one professional. He'll help you. He'll encourage you, so that the demandness will come down. Both will be in a reciprocal mode, so that they will enjoy the sex better and their family life will be good. And few people complain, doctor, whenever I approach her, she feels pain. Whenever I proceed, she feels pain. This pain can be a psychological one or a pathological one. It can be a psychological because she is not in a mood, she is not excited, not lubricating, it becomes a dry sex. That's why she gets pain. Or it may be because he's having, or both of them having a pathological problem, infections in their genitalia, that may be the reason why she gets pain. So this we have to examine and we have to guide them properly. So for psychological pains, we have to educate them that sex is not only for men, it is for both. Both players has to play the play. So be proactive, be encouraging, so that that will boost and ignite the male ego and male desire will be increasing. So both will enjoy. Another complaint, this is not that common. This is more common in the males when the female will complain, but little bit people, some male people also complained about her mouth smells bad, takes off my mood. This is another less common complaint they made. It may be because of the bare word hygiene, dental caries, or maybe because of the woman smoking, or maybe because of she's diabetic, uncontrolled diabetic, ketoacidotic breath, or she is in the habit of harsh foods like onions and garlics, or she may be alcoholic. So all these things has to be addressed, how to keep the oral hygiene, so that their sexual life will be normal and will come into the line. So by educating them to brush before going to sex, floss daily, use mouth rinse, and quit or avoid smoking, all these things educate, you have to educate them, give the suggestions. Few people complain that her genitalia is stinking. That stinkingness is because of the genital infections. So we have to educate them, go to consult a STD specialist. It may be because of the vaginal discharge or foreign body in the vagina, forgotten tampon, or rectovaginal fistulas. Any infections will be there. So that let the healthcare provider help them. So many people will come with forgotten tampons. And another point here I want to point out is, I have, this is our culture, Indian culture, and even the Asian culture. People who wash with hand during defecation, the woman particularly, they will wash from back to front. As a result of washing from back to front, all the anal fecal matter, specks of fecal matter, are all anal pathogens. We are making them to come onto the vagina and to the vulva. So this is a problem for recurrent vaginal infections. So we have to educate them regarding the genital hygiene, how to wash. It should be always from front to back. Because of their uneducation, because of their, though they are educated, they are uneducated sexually. So these are the people who are getting recurrent vaginal infections, irritations, itching. So we are doing a lot of work on this, and we are succeeding in to a greater extent in this area. Doctor, her body smells bad. I won't like it. This is because of the sweating and lot of these problems, bad odor emission from the bodies. So again, same problem, the personal hygiene here. Take bath, have a nice body spray, put sensation wave, room smells, odorless. I've put some room hygiene, perfumes, so that the sexual intercourse will be good for both partners. Both will get ignited. Both will get more desire. This is one problem which has to be addressed, because though the percentage is very small, but it is very difficult to solve this problem. Doctor, her breasts are very small. It doesn't excite me. This is the problem. Here the problem is, yes, undoubtedly the breast is the one that male gets excited by looking at it. No doubt about it. But when it is not there, we should not stop that. We have to educate the male community here. Forget about that. Don't get distracted about that, which is not there. Try to appreciate the other parts of the body. Try to learn to develop to love other parts of the body to get into the mood. That's the way we have to bail them out. Or don't look at the breast. Take the other ways of where we can do sexual intercourse, rear entry, lateral entry, so that you won't look at the breast and you won't lose your mood. Or else, consult a healthcare professional where they can advise you to go for some operations for the enhancement, breast enhancement surgeries. But it is always risky. So always we have to explain to them, give the choice to them. If they want, they can go, or else always the male person should learn how he has to relearn that, take off the concentration from the breast and more concentrate on other parts of our body, so that you develop intimacy and fantasy about that. Doctor, I feel burning whenever I have. This is a minority people because of the, again, maybe because of dry sex or maybe because of infections. So a healthcare provider can easily solve this problem. Now coming to the common complaints that are made by women against men. The most common complaint the woman makes against men is, doctor, this fellow flirts with other women. That's the commonest complaint. After going through the case histories, I always tell, off late I am telling this, my dear, flirting is not a cheating. It may be a problematic, but don't always assume that flirting is a cheating. You look it, you introspect it. Whether if it is something, if you are they have to inspect, pursue the partners they are with others, if they are not in love and affection with them. You try to introspect this and then blame and then put the diagnosis. If it is there, yes, you are loving him, you are giving care and affection, yet that person is looking at it, then there is a way of telling it, there is a way of discussing it, there is a way of making the bringing that into the discussion. Tell your partner how you feel if he looks into to other persons at an appropriate time, not in accusing manner, so that your partner doesn't feel attacked and he acknowledges how it makes you to feel, so that he will change his behavior. If you are able to succeed in that, fine, or else consult the healthcare provider. They will do that job for you. Another common complaint the woman make against men is, like a greedy impatient, why a man makes so much haste in during the intercourse? He leaves me halfway. This is another common complaint made by women. It's because people, that male race, after the pornography has become a liberalized one, after the smartphone has come into the hand, that has spoiled the show. So everybody can watch within no time, it is open thing, they can watch the porno. The porno never teach about the sexual response like as foreplay, play, afterplay. It is directly goes into the action. So these male race are tuned for that. As a result, they are going directly into the action and they are finishing their job and they are going away. As a result, whether they are not at all bothered about why the wife is excited or not, wife got orgasm or not, As a result, they are halfway. How to do what, how the sexual intercourse will be, how, what are the stages, how we have to proceed. So don't try to do like in films. Treat your sexual partner as a human being. Respect her likes and dislikes and discuss and educate them. This is another complaint made by the woman. Doctor, this fellow uses me like a sleeping pill. That fellow comes, finishes his job, and sleeps, starts snoring. So I am left with dissatisfaction. So here again, extension of the last question. We have to educate them to do more foreplay, enjoy the play. Don't forget about the after play. Kiss her, thank her for giving nice satisfaction, hold her tightly, appreciate her cooperation. Like this, we have to educate them. Is only education specific suggestion will to solve the problem. As Shalini Andrews told about implicit model, that will work out here very well. Another same extension of the same question, some people will complain he doesn't involve in love and romance and touching. He's highly interested in the intercourse. He just target oriented. So here again we have to educate them in the same way. Are Baba, pamper her sexual desires, pamper her body, pamper her thoughts in the foreplay, gently praise her, her beauty, her actions and the deeds, so that both will be in the mood, both will enjoy it well. Another complaint made by the woman against men is, Doctor, he expects me if ready for any time. Whenever he wants, I have to be ready. This is another common complaint. But biologically, it won't happen. That's why I always use this analogy in my patients. Whenever woman or men complain about this, I always say, Are Baba, do you have iron box in your house? Yes, doctor, I have. Once you start the iron box, how much time it takes? Immediately, can you iron your pant? No, sir, it takes some time. We have to wait some time till it becomes hot, then only you can do. That is what lady is. Stree is like that. It needs some time. Till that time, pamper her. Do foreplay. But whereas you like a switch, once you put the switch, light will be on. Whereas for the ladies, it's not like that. Stree is like a istri. It takes some time to get into the mood. So you educate so that everything will fall into the groove. This is another complaint where I don't know whether it is there in the Western countries or not. It is a common complaint in Asian countries. Doctor, during intercourse, this fellow talks more about other women. This is spoiling the show. I don't get any mood. I don't want to be with that fellow. This is again a case, a lot of psychological issues will be involved here. Lot of history taking and lot of analysis has to be done. Shamshul will be the better person for these cases. So we have to have honest discussion. We'll be educating them. Please have honest discussion with him. He may be loving you, but may want a different dress at night. He's unable to tell that, and that's why praising the woman who has you he has seen with the dress. You yourself introspect whether you are emotionally dissatisfied, or are you meeting his needs in the bed, or any unsettled resentment in between the relation, in between you in the relation. So all these things you introspect, then have honest discussion. If you're able to solve, fine, or else consult the healthcare provider. This is another complaint. This is the commonest in the men. Doctor, his mouth and body smells bad. Because men are more pan chewers, smokers, alcoholics, and more fascinated for onion, garlics, because they believe that it's aphrodisiac. So they will take more that. As a result, a lot of bad smell will come once we open the mouth. So this will take up the mood of the woman. You have to educate them again, oral hygiene, how to brush, how to eat, avoid. If you want to eat, if you can't avoid, at least eat after doing the sex, not before sex. So how to wash your mouth before going for sex. Stop 2 hours before, stop taking all these things. So we'll be educating about the oral hygiene. This is another common complaint. Doctor, performance-wise, he is fine. But the only problem with this fellow is he always scolds my family. He is after my parents. So that's why I am not getting mood. I won't like that fellow. This is because of this Asian cultural, because of lot of problems. Your mother told like this, your father told like this, they promised this much, they won't give this much, they did this much. Like this, lot of issues will be there. We have to ask them to introspect everybody, male and female, or husband and wife. You rectify if possible and reasonable. If unreasonable, have a honest discussion. If doesn't solve, then go to family therapist. They will solve your problem. This is again a medical problem. I feel burning and pain when he comes inside. Again, this is a same thing. Either it is a dry sex or it is because of the infections in between. We have to address them. This is another complaint, though not that common, but is a complaint made by a woman. Doctor, his organ is small. I am not happy with it. Here, we have to educate a lot here, because after examination, whether that question, that complaint is a realistic or unrealistic. So whether you have to tell him whether the complaint is a valid or only misconception, because we have to educate them. Length and girth are no substitute for intimacy. If it is an unrealistic question and misconception, we have to educate them. It is the intimacy that is lacking in the couple, not the size. Because really the micro penis is 1 in 1 lakh people. Majority will be normal penis. It's only their misconception. But before pronouncing that, we have to do physical examination, come to conclusion, then pronounce, and then give the advice how to improve their sexual intimacy. Remember that, because nowadays, as I told you, the smartphone is spoiling the couples. People are seeing this smartphone where they are showing gigantic penises or big penis, 9 inches, 20, 12 inches. These are all only possible in the porno, not in real life. And doing sex for 3 hours, 4 hours marathon. No human being on the planet can do such long. These are all only to ignite our desire. The porno industry will be doing. Taking that as a real, some girls, some boys, some women, some men, some wives, some husbands will be thinking that is real and this is not matching to that. That's why they are unnecessarily inviting the problems into their relationship. So remember that media, porno industry depiction of men penises doesn't represent the reality. We have to educate them. Then another complaint, this of late, obesity is problem increasing in every country. All countries are facing this problem, obesity and associated metabolic syndrome problems. When unfortunately the wife and husband both are obese, the syndrome of so near yet so far will exist. Doctor, this fellow throw all his weight on me. He doesn't know the technique of sexual intercourse. Yes, it is a justified question, genuine concern. We have to educate them again how to do without putting weight on her, or you can change not the routine of men on top or a woman on top position, you change it to the rear entry, change it to lateral right, so that this problem of putting weight on them can be avoided. Another question posed by the people is, Doctor, this fellow knows only missionary position, that is men on top. He doesn't know any other position. I am unable to tell him. I am hesitant to tell him, but I want more other types of sex, but I am unable to tell. This fellow doesn't know how to solve this problem. So again, we have to educate them. Arre Baba, these are all various ways where the husband and wife can enjoy the sexual intercourse. Whatever is happening between wife and husband is hygienic, is ethical. When both are partners are happy, forcing the other, it becomes unethical, and it becomes, in some countries, it becomes a legal issue. When both wife and husband, when they are willingly participating, everything is normal. As rightly pointed out by our Shalini Madam, that no infections will come as long as all the activities are between the two people. When third person enters into the relationship, yes, it becomes contaminated, risk will increase. So here we have to educate them how to do, what are the various ways to enjoy. So when both of you are liking that way, you will try to enjoy. After listening to all these things, or after treatment and success stories, what I came to know is all the people, the success story people tell, make sex a priority. Learn how to communicate. Learn how to touch. Learn how to kindle the romantic flames. Always keep a sense of humor in relationship, so that that relationship will be flourishing with 365 days, 24/7, will be healthily and happily. With this, I'll stop my presentation. Thank you for your patient listening. Now I request our Ritu Santwani ji. Please, she is going to talk about sex in pregnancy. Please start your presentation.
Yeah, hello, a very good evening to all of you. After hearing all of three stalwarts of the sexologist, I am here, the gynecologist, to discuss this problem which we are commonly dealing. Before I start my presentation, thanks to Mr. Kamath, thanks to Mr. Praveen, thanks to Dr. Aishwarya and Zydus Company for including me in this very interactive discussions. Sir Venkatraman sir, I have learned a lot today by all of your discussions. Thank you so much. So now I'm coming to the topic, that what is regarding the sex during pregnancy. This is a very common questions, very common problems we are facing at the time of the pregnancy. As a gynecologist, so many patients are coming and asking us. So as we know, the changes in the sexuality can be significant during pregnancy and in the postpartum period. A review of literature revealed that may women experience a decrease in the sexual desire and frequency of intercourse due to variety of her unspoken physical and psychological factors. Healthcare providers take a more active role in counseling obstetric patients about the intercourse during pregnancy. Just a second, I am not able to move the slide. Yeah, the nausea and vomiting of early pregnancy can prevent a woman from expressing her sexuality paradoxically at a time when the couple as a unit might feel the closest. Sexual desire and performance are also hindered by fatigue, which is common in pregnancy. Although decreasing in the second trimester, fatigue increases in the third trimester when the physical changes makes the sexual expression both awkward and uncomfortable. The heartburn is associated with reflux esophagitis, prevents the patients from responding sexually as they would desire. And as also we know, the urinary frequency and urgency also increases in the first and third trimester. That also become the hindrance to the sexual response, as can as constipation, fetal movement, and the back pain. The following changes may be experienced by the woman: sore nipples, feeling of fullness after the sex, increased vaginal discharge, abdominal cramping after the sex. The breasts are especially tender in the early pregnancy and in response to both hormonal and vascular alterations. The amount of vaginal secretions normally increases in the pregnancy and is further augmented during sexual arousal. And as we know, the cervix is more likely to bleed during the pregnancy because of the direct trauma from the penile thrusting, as the cervix has become very vascular at the time of the pregnancy. and the normal engorgement of the genitalia during pregnancy is further exacerbated during sexual arousal. Vasocongestion is not well relieved even after the orgasm, and the residual sensation of fullness in the pelvic organs may be uncomfortable enough to cause a woman to avoid coital activity. So orgasm may be accompanied by muscle spasms. Alteration in the endocrine environment during the pregnancy may cause the vaginal discomfort for some women, particularly in the first and third trimesters of pregnancy. The major concern, what the patients also share with us, for a woman in her perceived loss of attractiveness, about one fourth to one half of the pregnant woman feels less attractive than before conception. A pregnant woman's attractiveness as perceived by herself and her partner correlates positively to coital activity and sexual enjoyment. This beautiful article I got from this PubMed journal, so I thought to include this also. This is regarding the sexual activity during pregnancy. There are numerous, the numerous studies are presented in that. I have incorporated some in my presentation. The first one is by Master and Johnson, published the first scientific data on sexual activity during pregnancy. They documented a decrease in the first trimester sexual activity was noted, with an increase over pre-pregnancy levels in the second trimester and the greatest decline in the activity during the third trimester. Again, the study has been reported by Falikov and Bogren, found a similar decline in sexual activity in the first and third trimester, with the second trimester similar to pre-pregnancy sexual activity levels. One study has been reported by Kenny and Morris, which they found the less sexual activity only in the third trimester compared with the pre-pregnancy levels. Master and Johnson have reported that the effectiveness of performance declined in the first trimester of pregnancy in nulliparous women, whereas multiparous women reported a little change. During the second trimester in women studied with no significant differentiation between the nulliparous and multiparous subjects. Again, during the third trimester, all of the others have reported a decline in the sexual interest. The study has reported by Kenny found a decrease in libido during the third trimester only. Other has reported the decrease in the libido in women during the first and third trimester with no change from pre-pregnancy levels during the second trimester. Solberg and colleagues have reported the orgasmic function decreased as the pregnancy process progresses. Now, what are the behavioral changes? Because of the anatomic considerations, the coital positions differ as the pregnancy progresses. There was a significant decrease in the male superior position. In the last trimester, the side-by-side position was the most frequently used coital position, whereas the rear entry position, rarely used before pregnancy, also became the more popular. This is again reported by Solberg and colleagues. Again, I found a very beautiful article there again from the PubMed journal. The impact of the sexual intercourse during pregnancy on obstetric and neonatal outcome. The study has been done. They have published the data for the perinatal outcome. Data was collected by reviewing the maternal and neonatal medical records. In this, they have studied the obstetric and neonatal outcomes were compared between the women without and with sexual intercourse. 550 questionnaires were sent out, and out of this, 406 women responded, of which they find the conclusion of total 211, 52% women had sexual intercourse during pregnancy. In this, they have found the conclusion of this study, the most common complaint was only the lack of the sexual interest. Again, they reported the conclusion, the experience, frequencies, and timing of the sexual intercourse has no significant impact on any obstetric or neonatal outcome compared with those of the woman without sexual intercourse. So now, what are the risks are associated and reported? Prematurity. The two small studies have reported for the higher rates of prematurity in orgasmic women during the third trimester. All these studies failed to find a relationship between the orgasmic frequency and prematurity, premature rupture of membranes, premature labor, or low birth weight, fetal distress, Several studies have researched potentially negative effects of maternal sexuality on the well-being of the newborn infant, although coital frequency during the pregnancy has been associated with fetal distress and perinatal deaths, and these studies suffer from either small samples or incomplete control for the co-founders. Again, the studies have reported that no overall association between the sexual activity and either fetal distress or perinatal mortality. Some cases have been reported with the vaginal bleeding. Many women experience some vaginal bleeding or spotting after the coitus, especially during the first trimester of the pregnancy, and will continue to have a successful pregnancy. In these patients, the medical attention should be warranted if the bleeding or spotting continue for several days and accompanied by the passage of the clots and abdominal cramping. The chances of infection, the vaginal infections and prematurity. There is a study has been reported in CMAJ journal. The study group have found that the women who had the frequent intercourse and were colonized with Trichomonas vaginalis, Mycoplasma hominis, or bacterial vaginosis were at increased risk of preterm delivery. So frequent intercourse in women without such colonization was not associated with any preterm delivery. So now the theories are also be there for the sex for the induction of labor. What is the theoretical mechanism of the induction of labor by the sexual activity? The first, as the nipple and genital stimulation may induce the oxytocin release from the posterior pituitary, causing the uterine contractions. Prostaglandin release from the mechanical stimulation of the cervix may cause the cervical ripening. Prostaglandin in the semen may cause the cervical ripening. So the sexual desire of the woman is already declined by the last few weeks of the pregnancy, but the females who are still sexually active, only there are some contraindications are reported to not to have a intercourse sex at the time of the pregnancy in the cases of the vaginal bleeding, placenta previa, premature dilatation of cervix, rupture of membranes, history of premature delivery, or the multiple pregnancy. So what we advise for the practicing for the smart sex. So both the partners should follow the smart sex habits even during the pregnancy period to avoid the chances of getting affected by the infections. Better to use the condom at each time of sex. It is important to note that putting herself at the risk of infection may put the baby at the risk as well. So what are different positions? If both the partners are interested in enjoying a healthy sexual life during pregnancy, then about the different position that works best for both of when the belly grows and expands. First and foremost, be open-minded and creative as much as possible. So these are the some sexual positions which are recommended to consider to be safe during pregnancy. I'm taking one by one. Reverse cowgirl pose. The best position is during pregnancy sex. The woman is on top in the reverse facing the feet of the partner. No stress on the belly and the baby is safe. Other is reported as the policeman sex position, standing against the wall and spreading of the legs. Hands on the wall of the female can take the help of the elbow to stand to against the wall. Again, this study has reported regarding this laptop sex pose. The male partner sit on the chair and the female partner sits on his lap facing him. It is also comfortable. Other position has been reported, the stand and enjoy sex position. Stand with one leg resting on the couch or chair or bed. The male can enter from the behind. This is the safest during pregnancy. Corner of the bed, lie at the edge of the bed while the partner needs to stand on the floor near the edge of the bed. It is also safe and will not overweight the baby belly. So we also suggest some from alternative forms of the sex, the mutual masturbation as an alternative to sex, especially during the later stages of pregnancy, to have an enjoyable intimate moments as a couple. Oral sex, it is a good alternative to vaginal sex and it requires a less amount of movement on the part of a pregnant woman. Only the exception if the male partner is not to be suffering from the oral herpes. The some precautions what we advise when the patient comes for the consultation, not to blow the air in the vagina while enjoying the oral sex as it an air embolism to form inside the vagina, which can harm the unborn baby. Avoid the anal sex during pregnancy as it leads to an infection and can spread to the vagina. And to use lot of pillows to prop the female partner and to get her more comfortable. So now what to guide about the patient for the sex in the postpartum period. As we know, in the theoretically, early intercourse could result in disruption of the sutures, infection, dehiscence, bleeding, and hematoma or fistula formation. However, these complications are be more common after when the 3rd degree or 4th degree perineal tear or midline episiotomy in the patients with endometritis. However, most of the postpartum complications occur within the first 2 weeks, and very often the women are comfortable enough to have sex until the perineum is healed. So the most common postpartum complication associated with sexual activity is painful intercourse. In the review of the literature on the postpartum sexual dysfunction, 90% of the women resumed sex by 3 to 4 months postpartum, and sex was usually painful for the first 1 or 2 months, but then accordingly it improves with the time. A few studies have shown to quicker return to the intercourse if there is no perineal trauma was present at the time of the delivery. Some more things to share for the sex in the postpartum period. In addition, the increased rates of painful intercourse and sexual dysfunction has been noted with the operative vaginal delivery, with inconsistent results for cesarean deliveries. One more common cause for the painful intercourse in the postpartum is the vaginal dryness due to hypoestrogenic state induced by the breastfeeding. One study has been reported by Rowland and co-authors. They have shown that breastfeeding women were less likely to have resumed the intercourse by the time of the first postpartum visit compared with the women who were not breastfeeding. So while advising the patients about resuming the intercourse postpartum, there are no specific guidelines. It seems reasonable to advise them to try intercourse when they are feeling comfortable and enough to do so. So generally, the woman may experience some pain with intercourse, which can be ameliorated by lubrication and, if needed, the vaginal estrogen and the proper reassurance. Now, these days, some other lubricants are also available. So, in every patient, we are not advising the estrogen. We are trying first this non-hormonal preparations. So, now what's the take-home message of this? So, sex is generally considered to be safe in the pregnancy. Abstinence should be recommended only for the women who are at risk for preterm labor, antepartum hemorrhage due to placenta previa. The resumption of intercourse postpartum should be dictated by the woman levels of comfort. With this, I am ending my slides. So thanks to all of you for the patience hearing. Thank you so much. Sir, not able to listen you.
So could you please unmute your mic, sir?
Yeah.
Now I'm audible?
Yes, sir.
Yes.
Now we'll go to panel discussion. Something problem with slides are not moving.
So just click on the screen once, then the slides will move eventually. Click on the right part of the screen and then you'll be able to do it.
Yes, I got it. Right. Now the panel discussion is on the drugs used for sexual dysfunctions. So we are the panelists, myself, Dr. Venkatramana, Dr. Shalini Andrews, Dr. Muhammad Shamsul Hassan, Dr. Ritu Santwani. The first question is, what are the common drugs used for erectile dysfunctions? We'll start with London, Dr. Shalini Andrews.
Okay. I think things have changed quite a lot since the PDE5Is came in. So sildenafil is usually our first line, partly because it came off patent earlier, so it's cheaper for us to prescribe. I find sildenafil is a good starting point. Tadalafil is particularly useful on daily dosing because of its long half-life. So 2.5 to 5 milligrams daily puts back the spontaneity. Also particularly useful for older men with lower urinary tract symptoms. If they have prostate problems, tadalafil is a great drug which treats both conditions. It may have other benefits as well. So tadalafil, and the next thing to remember is if one fails or the other fails, combination treatment to salvage failure is useful. So we could give them regular tadalafil, top it up with sildenafil if needed. Testosterone replacement if they have testosterone deficiency, not otherwise. And if they have deficiency, definitely worth a trial of 6 months if there's no contraindications. If that fails, we go on to injectable therapy. And the one thing we don't do is things which are not licensed treatments. So we don't recommend any of those because that's just how registration works, and we stick to the science. So I think there was one question from a panelist about something else, and I'd say something else, but nice guidelines.
No, you have touched upon well. So all the drugs used here is oral drugs and injectable drugs. Oral drugs, as rightly said, sildenafil, tadalafil, vardenafil, amanafil, those are available. And then same time, testosterone. The injectable one is the alcostrudil. And we Indians, we are using more with papaverine and chlorpromazine combinations called bimix and trimix. So these are all the drugs which we use in the sexual dysfunctions. Now, once we use this, what are all the common side effects of these drugs we should keep in mind? Now we'll go to Dr. Shamsul. Hello, Dr. Shamsul Hassan.
Yes. Can you hear me?
Yeah.
So what we use here in Bangladesh, I can share my experience in Bangladesh. We have got tadalafil, we have got sildenafil, we have got vardenafil, and we have got avanafil.
Everything you have.
We have. Four. We don't have the urinafil. We have that in India. So what we use when we use tadalafil, frequently people tell about headache. Some of them tell about the back pain, and also some other complaints like hot flash. They have got severe headache, and also some blurring with the sildenafil. So the blurring of vision and the headache is the most common for our sildenafil patients, and mostly in our case, if we prescribe tadalafil, they talk about the back pain as well. Apart from that, there are some other issues like some very rare, but it is evident. Some people say that the erections for more than normal time.
Excellent. So majority of people, commonest thing is headache. Next commonest is flushing and dyspepsia. Then comes the rare problems, back pain and visual disturbances. As rightly pointed out by Shamsul, that the commonest two drugs, namely sildenafil and tadalafil. Tadalafil is more notorious for the back pains and for the indigestion. Sildenafil is more notorious for the headache, flushing, and visual disturbances, color disturbances. That's the commonest thing. Rest of the things, plenty are there. Rarely, patient may suffer with priapism, sudden loss of vision, and allergic reactions to the preservatives in the tablet. What are the food and drug interactions with these drugs? Again, Shamsul can throw your light on this.
For sildenafil and vardenafil, they have good definite food interactions. So we tell them to take at least half an hour before or 2 hours after. But nothing of this such is happening with tadalafil. We tell it you can try it anything.
Excellent, sir. Excellent. That's good. So that's the thing. So food always interferes with absorption, especially high fat meal. That fellow is taking sumptuous dinner and taking the sildenafil and going, it will be in failure only. And a few studies showing that taking a grape juice along with these drugs will interfere with absorption. Don't take alcohol with these drugs. So that will again decrease absorption. Always we have to ask the patients what are the other drugs they are taking, prescription, non-prescription, recreational, herbal, nutritional. All these things will have a role in the absorption and the pharmacokinetics and dynamics of this medicine. So these are all the things we have to inquire about this. It's a good number of drugs, alpha blockers, antifungals, blood thinners, barbiturates, beta blockers, the erythromycin antibiotic, protease inhibitors of HIV medicines, and medications for seizures, and phenobarbital, tuberculosis drugs like rifampicin, stanjon wort. This is more common in the Western world. So all these things will interfere with this drug absorption. So hence we have to
Especially
inquire
for especially if someone is getting the antihypertensive,
yes,
we just tell
absolutely.
them to make a space of 4 hours gap.
Yeah.
Otherwise,
Yeah.
there may be postural hypertension.
Now we will move on to that Shalini. As I told you, sildenafil and tadalafil are the commonest drugs because they are relatively cheap. In India, we get for common man purse. So among these two, in between these two, which is the best and why it is best?
I actually don't have a personal choice between one or the other. And I think sildenafil works quickly. Tadalafil, as an on-demand preparation, other than heavy meal, which doesn't seem to be much of a problem here in terms of what people have. And it's more the grapefruit juice, not the grape juice. So wine is okay, a bit of alcohol before sex is okay. People like it. just allowing you that. So on-demand dosing between the two, there is not a big difference. Individual patients may have side effects. So when they have a side effect with sildenafil, visual disturbance particularly, I might move them to tadalafil. But daily dosing, I think for men, but again, men and women's sexuality are not that different. They're not always in a mood for it, but when they have the mood for it, it's nice to be able to do that. So for daily dosing on that, especially when people are sleeping with a regular partner, on the nights they feel like if they can have sex and it's only a small dose. So daily dosing tadalafil is one of my preferred options for many patients, particularly the older diabetic.
You're absolutely right, madam. What we practice, same thing here. When sex is unpredictable, particularly happens in the youth, who don't know, sir, suddenly chance will come, we'll enjoy it. So such people, sildenafil will be a better choice because it acts quickly, a short half-life, so that will be a better choice for them. Already elderly people, middle-aged people, where sex is a predictable, as rightly pointed out Shalini, they know pretty well that at night while going to bed we'll have the sex. Tadalafil will be a better option because it's long acting, need not take drug every day. At the same time, less affected by food, less affected by alcohol, and more beauty is it is better with people who are having prostate problems. That's why tadalafil will be a better drug for them.
Venkat sir, I have one query. Sir, because I am with the panel of the sex expert. Sir, I have one patient. Patient's husband is on Aptoin drug, for this epilepsy from last 3 years. So, can you suggest me which drug is the drug of choice for this erectile dysfunction for him?
Again, the same question: whether the sex is a predictable and unpredictable. If they are having a regular, predictable sex, tadalafil is the better choice.
Okay, sir. Okay, sir. Okay. Thank you so much, sir. Right. Thank you so much.
Now, having known the variety of drugs, how to take, what are the drug interactions, now let us know a bit about what are the contraindications for these PDE5 inhibitors. Shamshul bhai?
So, mostly the only contraindication I am scared of is if someone has got a recent MI. And it's not about the tadalafil, it's about the sexual intercourse causes a lot of MET, lot of physical exertion that may be contraindicated. And if someone has got some cardiac issues, we need to assess whether they have got, the Princeton criteria, whether they belong to the low risk, intermediate risk, or high risk. If someone has got more than 3 issues like recent MI, myocardial infarction, if he has got unstable angina, if he has got arrhythmia and so on. So sex is deferred. Sex is not being practiced. And when there is a confusion, we send it to cardiologist. Apart from that, if anybody is taking nitrates, we tell that you need to at least have a 48 hours gap with, in case of tadalafil, or in case of sildenafil 24 hours gap. Otherwise, I don't think it's a big problem. So if anyone can climb stairs for 3 to 4 hours,
that is the idea.
You can have sex.
Because a patient who comes to you with a lot of belief, and if you are referring to the cardiologist, echogram, this and that, patient say, Baba, tell me whether I can participate or not. I came all the way, but you are making me to undergo battery of tests for the 10 minutes play of sex. Why are you subjecting me? So the best way is, if you are able to climb 2 states, 40 steps without stopping anywhere, yes, you are passed with the exam, go and have sex. So that is a broadly. It will have its own implications and the negativities also. But broadly, we are justified in giving that suggestion.
Or 1 mile walk.
1 mile walk, yes, yes.
20 minutes time.
That's the thing. So as I rightly said by Shamshil sir, nitrates is the absolute contraindication because it is dangerous drop of blood pressure will be there. Lot of mortality will be there. We should take care about this. Then other things like multiple myeloma, leukemia, sickle cell anemia, retinitis pigmentosa.
Sickle cell anemia.
All these things we have to inquire before prescribing the drug. Recent heart attacks are nicely dealt by our Shamshil's boss. Aortic stenosis, hypertrophic cardiac myopathy, chronic heart failures, all these things will become a contraindication. Apart from this, stomach ulcers, particularly sildenafil is notorious for regurgitation and this one burning. So people with that problems and severe renal impairment, and people suffering with Peyronie's disease, a lot of fiber plaque on the penis will have problems with this. That we have to think of. Now we'll go back to Dr. Shalini ji. What are the other areas where sildenafil can be used?
So in terms of sexual dysfunction in men with premature ejaculation, if they also have a component of erectile dysfunction, we use sildenafil.
Excellent one.
And one other situation where I use sildenafil is for women, female sexual dysfunction. So sildenafil wasn't used much in women with sexual arousal disorders because women have a combination of, cerebral sexual arousal and genital sexual arousal.
Excellent.
Some women may not have, they have a problem specifically with genital sexual arousal, and sildenafil is very useful in that group.
Excellent. There are many more indications are there. We will go to Ritu ji. Since you are infertility specialist, are you using sildenafil in your practice?
Yes, sir. Yes, sir. Sir, we are using in lot of other cases. In the sexual dysfunction, besides that, we are using in the IUGR patients also we are using, and
yes.
I'm infertile.
Yes, that's what.
Yes, yeah, and
that's
sir, we are using.
Yes,
sir, and we are using for the thin endometrium. That is a very important because we are dealing the IVF. Yeah, we are using the for thin endometrium. Very good results with this.
Yeah. Apart from this, we can use it in pulmonary hypertension. We can use it in Raynaud's disease. Dermatologists use it in scleroderma and systemic sclerosis. As rightly pointed out by Dr. Shalini, female sexual arousal. Gynecologist, as I told you, used in infertility clinics. They will use in the form of gel, intravaginal gel, along with the clomiphene citrate to increase the endometrial thickening. So these are all the various indications where the sildenafil is more useful. Over which, recent 2 articles have come saying that use of PDI inhibitors, particularly sildenafil, is anti-tumor activity. Sildenafil citrate with the flu vaccine, both are working in reducing the TNF alpha activity, tumor proliferation activity, flip expression activity, and decreasing the ABC protein activity. At the same time, it's a good drug for the platinum drug poisoning, it becoming resistant. So these are all the various advantages whereas other areas where sildenafil will be useful. Now we'll come to other topic. What are the other common drugs used for ejaculatory dysfunctions? Shamshul bhai, can you throw light on this?
Can you come again? I'm looking at the chat box. There is some question.
Common drugs used for ejaculatory dysfunctions. It's your
in
topic.
In Bangladesh, we use dapagliflozin, and I have a personal choice on paroxetine because it has got a very long half-life. It's a long ILT. Yes. And also sometimes we use citalopram or other drugs like sertraline, but mostly my preferred drug is paroxetine.
So the drugs that are available is fluoxetine, sertraline, paroxetine, citalopram, at the same time dapagliflozin. This dapagliflozin is the latest addition to the doctor's armamentarium way back in 2009, but even certain countries don't have this, particularly America, still US FDA not approved. European communities approved this. Even Mexico also has approved this. All Asian countries is available. So these are all the drugs among which dapagliflozin is a very short half-life period. That's why they advocated it. But many patient reviews and post-market reviews clearly selling that paroxetine and fluoxetine are the better drugs where patient is more benefited. But it's having its own disadvantages. We will discuss about that. Otherwise, these are all the drugs that are available for the treatment of ejaculator problems. What are the common adverse effects of these drugs, Dr. Shalini ji?
I was thinking that should be a question for the psychiatrists because they use quite a lot of that.
Yes.
Shall I pass it on to you, Mohammed? You can tell us.
Paroxetine mostly causes in 2011 I have heard that in a ESSM conference that it causes DNA fragmentation and it is more than 30%. So those couple who are planning to have pregnancy, the male partner should not take paroxetine. So that is one way. But in recent other studies, it is also seen that escitalopram has got also some variable changes in the semen parameter. They don't say that it has got DNA fragmentation, but you know the famous expert Egekan Serifoglu, he has a study. He said that escitalopram also causes. But mostly from my practice, I prefer escitalopram over paroxetine when the couple is planning to have pregnancy, and which is a issue because they have tried several times not getting pregnancy. But apart from that, it causes anorexia, nausea, diarrhea, vomiting, and other. And also in case of female,
that is the common thing. That's
in case of female, they have got a lack of desire, sexual desire goes down. They have got arousal problem, and also they have got orgasm problem. And as we all know that this drug is being used for enhancing our orgasm time, ejaculatory latency time, it also causes for some person to develop anorgasmia. So that's a problem. And also low desire because it reduces the cerebral testosterone and thereby, reduce the desire. So there are a lot of other factors, but mostly these are the issues.
I think the dry mouth and the sort of, the SSRI side effects, the psychiatric side effects,
parasympathetic effects will be there.
It is more of the tricyclics, the clomipramine. It's a drug TCA, but which is more used for premature ejaculation. But like Shalini rightly pointed out, that all SSRI causes dry mouth, all the GI symptoms, but less
particularly paroxetine.
Yeah. Paroxetine causes more, right? Absolutely right.
Yes. So these are all the list of common complications, side effects like nausea, sexual dysfunction, headache, vomiting, dry mouth, weight changes, risk of bleeding, and discontinuation syndrome. Because of these complications, once the patient stops it abruptly, again the discontinuation syndrome will come into picture. And the mental behavioral side effects will be there, akathisia, suicidality, hypomania, all these things. So these are all the various common side effects which we have to educate the patient when we are putting on this, so that they will take it regularly as advised by you. So these are all the things that will come into picture. Now we'll go to other area. What is the role of testosterone in female sexual function? We'll go to Ritu Santwani.
Yeah, thank you, sir. So the testosterone role is reported for the female sexual dysfunction, for the arousal, especially in the woman where the oophorectomy has done, for increasing the pleasure, the aging. But sir, personally, I don't have any experience with the use of this drug. Because as it is reported, means we are giving some patients DHEA also, methyl testosterone also, testosterone gel is also reported. So basically, but I am giving the non-hormonal. I have no personal experience with the use of this testosterone for sexual dysfunction.
Sexual dysfunction is needed for the desire purpose in females. When there is a low testosterone because of the various factors, or maybe postmenopausal or premature ovarian failure or oophorectomy or any malignancies, where there is an indication is there to improve their sexual desire. That is needed. Surgical menopause or adrenal insufficiency and these areas. Shamshul Bhai, what is the role of testosterone male sexual function? Male.
In case of male, it's a very vast topic. Probably in next week
No,
you will going to
that
cover.
we'll do next webinar for
But
that.
what I'm telling that what is the common malpractice in Bangladesh?
Uh-huh.
Mostly, some people have got hyperactive sexual desire disorder.
Uh-huh.
Their testosterone is pretty much right. Nothing wrong with the testosterone. But since they have got a problem with the the low desire due to some other reason, they are being put in. ISSM has got a very clear indication
Uh-huh.
when in two different occasion blood sample testosterone between 8 a.m. to 12 p.m. is less than the range. Number one.
Yes.
Also, they have got the symptoms, specific symptoms like
Yes. Yes.
reduced morning erection, erectile dysfunction, and low sexual fantasy, and along with that sleep disturbance,
Yes.
low protein, high fat. Only then you can provide testosterone, provided this guy doesn't want to have children.
Yes.
If they want fertility, so even in a young person with low hypogonadism, you cannot give them testosterone because that will compromise their fertility issue.
Yeah, that we deal in detail next webinar.
Next week.
So the testosterone in males will affect all areas of the sexual response, not only desire, but also erection, but also ejaculation, but also orgasm. So all areas there is a role for testosterone. So as rightly said by, we have to evaluate where the testosterone is needed, because testosterone makes the person male. It makes or breaks. If it is low, the male is broken. If it is high, good, he is a male person, because it is having effect on the brain, bone marrow, bones, muscles, skin, everywhere it is effect is there. So we have to be under the impression that it affects all the areas, and we have to use only establishing the hypogonadism. That the same answer is coming now. We'll go to again Shalini ji. When do you recommend testosterone in male functions?
So usually we measure the testosterone levels. And if the total testosterone is less than 10 on 2 repeated measurements, we definitely consider treatment. Less than 8, definitely treatment. Less than 10, do it twice. Between 8 and 12, we can consider a trial of testosterone for 6 months. Yes. And the things I would use in that situation is calculate free testosterone levels. So if you go on the ISSM website or any of the other free testosterone calculator tools, we can use SHBG to calculate the free testosterone. If that is low, that's one more reason.
Excellent. You are pointing out a real thing, because no lab is doing the free testosterone estimation. It is the only calculated free testosterone. Otherwise, the labs are just giving a report, one report, because it has to be done by reverse equilibrium process. No laboratory is equipped for that. So it is always a calculated free testosterone. That a calculation formula is given in the website. Every healthcare doctor can refer it. Excellent, madam. So testosterone replacement therapy is clearly indicated after establishing the existence of clinical hypogonadism by evaluation confirmed by laboratory evidence. What are the contraindications? Since Shamsul is not there, you take the question, madam.
Okay, so contraindication, before I put anybody on testosterone, if it's a young man, I'd ask them of their parenting desire. So wherever they are, ask them if they plan to have children, and if that is going to be something, it inhibits spermatogenesis. So that wouldn't be the ideal treatment for them. Second thing to do is, especially for the older man, is to do a PSA estimation. Testosterone does not cause prostate cancer, but if a man's got prostate cancer already, testosterone will make it grow bigger. So it's important to rule out prostate cancer. So digital rectal examination and a PSA measurement is minimum. Once established on testosterone, we measure the hemoglobin, because it can cause but that's not a contraindication, really. I mean, we can have some, we can take some blood out and treat the polycythemia and carry on with testosterone therapy. So those are the three main contraindications.
Yeah, Shamshul bhai. Hello, unmute yourself, Shamshul. Shamshul, unmute yourself. Now, what are the contraindications of testosterone therapy? Already Shalini has given you insights like prostate risk, fertility, then you add something to that.
See, there are though I don't read it for urological perspective, there are certain the prostate cancer which is highly androgen specific. So it was a long series, and Shalini has pointed out, and that was an issue. The urologist said they need to check their prostate because before giving.
Anyhow, we have to do without doing PR. We should not start the
Yeah.
testosterone replacement. That is
Apart from that, the polycythemia is there because if you give them testosterone, they may develop the polycythemia. If they have got sickle cell disease and some other disease, we have to be careful.
Excellent.
And also, if there is a cardiac issue, like Shalini said, that there was a consensus in a big study that said that testosterone addition causes a huge risk. But there are 6 different societies, they have commonly pointed out that testosterone addition doesn't point out any further cardiac risk. Rather, it's to some extent is cardioprotective. So that's a debate going on, whether it's a cardiac, it causes cardiac problem, or it's helpful for the cardiac disorder. So, but we should be cautious, needs to be cautious and under guidance. And also, while the person is getting testosterone, they should have a regular periodic checkup for CBC and the other things. Because
we have to watch for hematocrits.
Hematocrit, if PCB is more, you need to.
Because testosterone is notorious for the water retention. Hence, there is a risk for the fluid retention is there. That's why grade 3, grade 4 cardiac failures, we should be very careful. Not an absolute contraindication, but it's a relative contraindication. We should be careful.
True.
Right? This is the real question, most burning question in the community now across the globe. After 1998, the scenario of management of sexual dysfunctions has changed. There's a paradigm shift is there. 1998, because I am referring introduction of the Viagra. Even today, the research is clearly showing that 30% of people are not responding to these PDE5 inhibitors. Those people who are responding also coming back after repeated using, saying that, doctor, this dose, my body is not responding, need more dose. You might have observed in your patients also. Now, my question is, when the patient fails to respond to PDE5 inhibitors, how to proceed? Shalini ji, throw your task.
The first thing I'll say is take a good history, because man needs desire to perform. So if he doesn't desire the partner he's having sex with, no amount of PDE5 is going to help him.
Excellent.
So good psychotherapist first. And second thing is, if it's a true PDE5 failure, you can increase the dose. You can double the dose. I put them on daily dose tadalafil, because there is a baseline level, and then we can top it up with on-demand. Be careful with other medication, if particularly anything that might decrease the blood pressure. And very gently do it. So I sometimes do tadalafil and then add some sildenafil on top of that. And then again, they might need a little bit of a start. So diabetics, particularly things like sex toys, cock rings with a bit of vibratory stimulus might be helpful in getting them restarted. They just need that little bit of addition on top of the PDE5Is. Things like vacuum suction devices. Again, sometimes men like using it, not always, but sometimes one on top of the other, just for a little bit of extra help. If all those measures fail, I then go on to prescribing them an injectable. So we've got the prostaglandin E1 injectable, the Invicop. And then we have this new one called Invicop, which is one you use, VIP with phentolamine combination, which is much better because they still need desire, doesn't cause cold glance. Risk of price is pretty low with that, so we go on to injectable at that stage.
Thank you, madam. Thank you. You are led nicely. So counseling is the first thing, whether the patient is taking the tablet correctly, what are the things to avoid, etc., has to be discussed before putting the tablet. Adequate stimulation is a must for the drug to act. Keep comorbid conditions in control. Uncontrolled diabetes, again a poor response will be there with sildenafil. Take 4 to 5 times to participate, then say that it is not working. Taking the tablet first time and coming back, doctor, this is not working, is not a genuine not working. Ask him to repeat, to use it 4 or 5 times, then do sexual intercourse, then come back for your feedback. Dose escalation to the maximum safety levels. Then another important thing is adding testosterone after confirming that sildenafil is not working, because testosterone, a minimum dose is needed for the nitric oxide synthase to manifest, to express. That is needed for the sexual response cycle to initiate. That's why people who are not responding to this, after excluding all the things, think of testosterone, see that the person is hypogonadal, establish that clinically, then give testosterone top up on this, the patient will do wonders. So this is the flow chart that whatever Shalini and myself told, this is the flow chart to go. Now we'll go to Dr. Shamshul Bhai. Does penile extracorporeal shockwave therapy is useful? This is now a fashion of the day. I have seen even in the Korea conference, even in the Bangalore conference also, discussing a lot of things about this. What's your opinion about this?
We don't have any so much of experience in Bangladesh, so I cannot give a hand-on experience, but I can go back to the past in 2011 when the Vardi, Vardi and his colleague has started the process. And every year I went to the next couple of years, I went there, I was asking Boaz. He was the associate of Vardi and he was attended ESSN school. So, and I think it will be reserved for all those cases who are non-responder to PD5. Again, PD5 has, if they are non-responder, you have to wait for a couple of more times, because if you are giving more times, then non-responder will be converted to responder. So only you can reserve it for other people who are giving, who have already tried all the measures. And I have seen some studies in India as well. They have given the very all the patients for the first time they have given extracorporeal shockwave therapy. So they could have either be improved with tadalafil and sildenafil. So it's very difficult to say. So I don't have any right experience, but its efficacy is moderate.
Yes. So this procedure is reserved for all the available treatments. When they are not responding, this is a choice, last choice. So by this, it is a non-invasive drug-free procedure where this ultrasound low intensity sound waves supposed to increase the angiogenesis in the corpora cavernosum, in the penile tissue. So the company claims so many things, but patient-wise, so results, not that good results, even in India also. Another thing is, nowadays we are going everything for stem cell therapies are coming into picture now. For everything, this is stem cell. And good resource for stem cell is our platelets. So platelet-rich plasma, can it help in these sexual problems? Dr. Shalini ji, what's your experience in this?
Okay, okay. One of the big resources I will direct everybody is something called Sexual Medicines Review, which publishes data on all these studies that everyone presents little studies and we don't know what to make out of it.
Exactly.
So there was a wonderful review by Scots in 2020 looking at platelet-rich plasma. There's something like 638 centers which are doing this. And there's a global presence, but there is no scientific evidence published to establish an evidence-based risk-benefit profile for platelet-rich plasma in erectile dysfunction. So as things stand, we need proper clinical trials to examine the role of it and accept it as a standard of treatment.
Yes, madam. Yes, because I have some experience, 5 to 6 patients I too tried, but not that much encouraging results.
Sir, can I add one thing, if you permit, Venkat sir?
Yes, please.
Sir, but I am using left and right for the female sexual dysfunction who are not responding to this drug therapy. I am giving O shot and G shot at my center. Very fantastic results I am getting. I am using very often this PRP therapy.
Very good.
Yeah.
For females,
for the female sexual dysfunction. Yes, sir.
Good, very good.
Yeah.
Good input. Good.
Yeah.
Now, what are the latest modalities in the pipeline for treatment? Shamshul Bhai, you are not there. Now again, Shalini has to come to rescue now. So latest, Shamshul has come. What are the latest modalities in the pipeline for treatment of sexual problems?
For sexual problems, some injection therapy is being tried for female ejaculation, and some stem cell therapy is there. But I'm not very up to date about the recent advance apart from the PD5, because since the inception of 1998, since the inception of sildenafil, it has to some extent has got stunted. Like after sildenafil, tadalafil, udinafil, mildenafil, I'm not sure about the recent update. What is some magic pills?
Now,
Shockwave therapy is being considered as a new line, but still
yeah,
its efficacy is not that good. But we are
the,
really
late,
looking for some
the
other.
latest things that are in the pipeline are apomorphine nasal spray. Is in the
That is there.
it's the phase 3 trials now. Alpostadil in the cream form for topical application. It is also in the trial. Melanocortin activators, that is there available injectable form. Now they are trying intranasally as a spray. Gene therapy. Now scientists have found out that the gene that is there in the short arm or long arm of the chromosome 6, that is responsible for this problem. So now the gene therapy is also in the trials. We have to wait for that bright day. If it comes, the business, all the people will shut the business of sildenafils. Everybody will go for this gene therapy. The stem cell therapy, which we discussed, PRP also, apart from that, many other drugs, major tissues are used, particularly fat cells are injected into this as a stem cells. The next one is the nitric oxide polymers. So injection, intracameral injection is also there in the pipeline. Penile stents. Why cardiac stents? Why not penile stents? Researchers are doing research in this way. Penile stents, people who having closed vessels, particularly because of the trauma and because of the accidents and injuries for the pelvic area and for the penis. So where penile stents. These are all the various modalities in the pipeline. Now we'll go to Dr. Ritu Santwani. What are the US FDA approved treatment for female sexual dysfunctions apart from your PRP?
Sir, what is reported is the flebenserine and the bremelanotide. But for both, I have no experience. If anybody has the experience, please share and increase my knowledge.
Yes, these are the only two drugs that are US FDA approved. Rest of the drugs, what we are using, off-label only.
Yes, sir.
Not approved drugs. So this flebenserine is a oral drug. It has to be given once a day, and the dose is 100 milligrams. It has to be given at bedtime because the risk of hypotension will be there. The patient may fall down. That's why it has to be taken at the bedtime and then participate in sex. And if you taken after 8 weeks, if no improvement, this drug won't work for them. They have to discontinue that drug. Because of the lot of side effects with this drug, particularly alcohol, other areas, people acceptance, patient acceptance is very poor in this flebenserine. That's why it's not becoming a good drug of choice. The second one is this is the black box warning of the flebenserine. Alcohol, contraindications because of other drugs, and contraindicated in hepatic impairment. Second drug is an injectable one, bremelanotide. It has to be given subcutaneously like an insulin injection. It's a self-injected mode. This drug has to be taken 45 minutes before the anticipated sexual intercourse. And this drug has to be taken only 4 to 8 times in a month. You should not take every day, 30 days in a month. The company warning is maximum 8 shots in a month. Should not exceed more than 1 shot per time. And if it also doesn't work for 8 weeks, you have to discontinue. This is also of no use. This is a recent addition. It came last year only.
Yeah.
Whereas the flebenserine came long back.
So but these are not available in India or available by any company?
No, we can import. Right now, no Indian pharma company is manufacturing. It is importable.
Yeah. Thank you so much, sir. Thank you so much.
Right.
Yeah.
Now we'll go to Dr. Shalini. What's your experience on the Botox in vaginismus?
Again, I personally don't have a lot of experience. I did have a colleague who used to do Botox for vaginismus, injection into the bulbous spongiosis. I think Mohammed again has worked in his clinic. It's an experimental treatment, but there is one large study of about 238 patients done in Turkey where they found very good effect, used in addition to therapy and used in addition to vaginal dilators afterwards. However, that study didn't have a control group, but does have a 1-year follow-up. So sounds promising, but again, we need more evidence before we can recommend it thoroughly. Maybe for a minority of patients with an experienced injector, it's something to try.
Shamshul, can you throw some light on this? You have any experience? Then it is the last resort because it is a salvage regime for all the treatments when they fail for vaginismus. It works well, but only thing is patient, it has to be done under anesthesia. Patient has to be admitted. There's a protocol how to do Botox and how to do follow-up for this. It works well. I have experience for 4 to 5 cases when I am working in the institute. Now after retirement, we can't do in the clinics this one. This is available as a Clostridium botulinum toxin type A1 with the 100 to 150 units in the vial that has to be diluted before injecting. Intravaginally, we have to inject it under anesthesia. At the same time, we have to give locally long-acting local anesthetic bupivacaine so that we can do dilatation even after giving this botulinum toxin. And the patient, once recovers from anesthesia, she should feel comfortable with a dilator inside the vagina. Then she can feel comfortable doing self-vaginal dilatation so that the patient will come out and will have normal sexual intercourse. It works, but it is a last, it had to be reserved for when it has to be used when all other treatment fails. So with this, now we are completing the panel discussion. We will go to audience questions if there are any.
Yes, sir, definitely. There are a lot of questions from our audience. Yes, sir.
We'll go to questions.
Yes, sir. I will read it for you, so on behalf of you, and you can direct the questions.
Yeah.
So our first question is, how long would you recommend the use of sildenafil and depoxitin combination in acquired premature ejaculation?
Shamshul, you are there on the line? Shamshul? Otherwise, Shalini, you take.
So how long is a piece of thing? So acquired premature ejaculation again goes into why they acquired it. So lifelong will need it for life. For acquired depends on why they need it. And maybe if the situation passes, they can come off it. But realistically, it's as long as it depends on the individual patient. But they can stay on it for as long as they want. But if they're needing it long term, I'd probably suggest going on paroxetine rather than on-demand depoxitin.
Excellent. Because the premature ejaculation is of 4 types. For the type 3 and type 4, where limited time is sufficient after addressing the causative factor. Limited time of the sildenafil and depoxitin combination will work. It's not a lifelong procedure for them. Yes, next question.
Yes, sir. Next question, sir. So this is by Dr. Syed from Hyderabad. The question is, can we use Eratex daily? Now, there is a similar question come up by another viewer. L-arginine and fenugreek combination, was it helpful in increasing male sexual desire? What are your clinical feedback? So I think we can club these 2 questions and answer.
Yes. The evidences are there, scientific research is there, and my experience is there. These will work because they supplement a lot of L-arginine and particularly will supplement nitric acid synthase. At the same time, fenugreek supponents will block the SBH, sex hormone binding globulin. Testosterone going and getting attached to that will be blocked, so that testosterone, free testosterone availability will be more with the patients. So definitely it will be there. At the same time, we have to establish that that particular patient is having less nitric oxide synthase. Or this patient is having, there is a SHBG is increased. Such patients, excellently it works. Sometimes we have to use some PDF inhibitors simultaneously with this combination of fenugreek and L-arginine. Apart from that, adding a zinc is much more beneficial. Adding magnesium is still more beneficial. So all these things that are there in the yes, it works very well. I will take the experience of our people, Ritu Santwani. What experience you have, madam,
Yes,
on
yes,
this?
sir. Totally agreed with you. I have got a very fantastic results. I am using this drug from last January. So I am getting very good results. I already shared the excellent results with Mr. Praveen. I told him that I got very good results. I am using for both, for male and female sexual dysfunction.
And our foreign speakers, it is difficult for them because probably they might not have used this. What about your experience, Shalini ji?
No, we don't use it because two things. One,
Yeah.
we need evidence based to actually do it. So one
Yes,
thing I would
yes.
really encourage people who say we have so many patients who are doing really well is to please do a trial, because if you do have a case control trial or a randomized control trial, that will be really helpful in bringing some of these treatments forward.
Excellent. That's true. We'll
So,
go to
sir,
next question.
yes, sir. We'll go to our next question. So our next question is, what is the exact percent of free testosterone needed to enhance libido?
Shalini has done, you will take this question.
Yes, it's, so if you go to a testosterone calculator, it's an online calculator. You put the total testosterone, you put the albumin levels, and it calculates it for you. I think it's I can't remember the exact number, it's something like 0.385 or something around that line. So it'll tell you whether it's your right level or wrong level.
Excellent. It is there in the website. One can,
yes.
Any doctor can refer it.
Any doctor can look at it.
Yeah.
Okay, so we'll move on to our next question. The question is, what dose of sildenafil is used in IUGR in females and how long?
This I can answer. Yes,
yeah,
yes, this I can answer. Yes,
it is,
yes. The recommended dose for IUGR is 25 mg 4 times a day, but we are not using 4 times. We are usually using the 25 mg 3 times a day. Because with the orally giving the tablet, again the patient is complaining of due to hypotension, headache and all that. So we are advising for this vaginal preparation also at the time of IUGR, and we find the excellent results. There are some patients who are not able to tolerate 3 times also, we are giving for 2 times, 25 mg BD or TDS. Like this we are giving. Minimum for 6 to 8 weeks, not like that in 1 or 2 weeks the patient will get the result. Minimum for 6 to 8 weeks. Yeah.
Aishwarya ji, next question.
Okay, sir. Next question. This is by Dr. Vishnu from Mumbai. Is there any hormone or hormones that can increase the breast size?
Yes, this is the, again, as I told you, many men complain against women. Now the hormones are risky. Number one, there is no clinical evidence that will increase the breast tissue. Number two is risky. So instead of that, people used to augment breast augmentation by giving silicone injections there, but subsequently proved to be carcinogenic, even that also withdrawn from the market. Now there are certain physical exercises that will increase the pectoral muscles to give a false impression that breast tissue is increased, giving a false impression that is there. Now I will take the opinion of Shalini. She will throw some
I'd
light
love
on
to come in on this, because for hundreds and hundreds of years, people have been telling us women what our body should look like. Please stop.
Yes.
I think what we need to tell people is, look, be happy with your body, be happy with your thing. And if you're not happy, you need a therapist first, and not surgeons, not people who actually do it, because you can have hundreds of surgeries and still not be happy with your body. And so I think it's psychoeducation again. And like female genital mutilation, vagina shrinking surgeries, I think in my mind comes as one of this. And any mutilating surgery or mutilating treatments, please think again.
Because nowadays reconstructive surgeries are going in the community. It's picking up. We have to educate them in this area. Yes, Rituji.
Yeah. Agree to you, Dr. Shalini and Venkat sir, but we are these days giving the PRP therapy, that is autologous, to make the cleavage line prominent, to make the girl or wife more sexier. I have myself reported a study of more than 60 patients, a very dramatic results and very good results I found with the PRP therapy. To make the cleavage line prominent, I am telling, not telling that,
Because I am also doing, but I am not getting any improvement. I am unhappy personally. Patients are living, okay, doctor, little bit better. Okay.
Sir, we will discuss offline. This. Yeah.
Okay. Yes, sir. So our next question is by Dr. Anil from Madhya Pradesh. Can sildenafil or tadalafil be prescribed in a patient taking metoprolol?
Yes, we'll go to Dr. Shamshul Bhai.
So,
Unmute, Shamshul. Shamshul, unmute.
Like I said earlier, any PD5 if you want to give, you need to have a spacing with any drugs which can alter the blood pressure. So at least there should be 4 hours gap. Number one. Number two is prescribing tadalafil and sildenafil is not very commonly practiced. It is to some extent off-label. Some clinicians give. They give daily dosing. On the top of that, they give sildenafil. But
and the question posed here is, yeah.
So
whether it can be taken along with propranolol, metoprolol.
Metoprolol, if you have to space some time, at least 4 hours gap, and I would recommend to give single PD5, not under the top of another, because it can reduce the pressure. Hypertension can be a result. So be cautious, go slowly, and if you think that it's fine, then you should. Ideally, 2 PD5 should not be given randomly, and not when
probably the doctor. The idea of doctor asking this question would have been: patient, the cardiologist has prescribed or physician has prescribed antihypertensives to take in the night. Sexologist has given sildenafil to take in the when you are having sex. Usually sex happens in the night only, unless it is a young age where it can happen anytime, anywhere, 24/7. Otherwise, it's night only. So when night 2 drugs has to be taken, is it okay or not okay?
I don't. I usually refer these clients to the my cardiologist, and I ask their opinion. Metoprolol should be safe.
Relatively, but not absolutely.
Not absolutely.
ACE inhibitors are the safest along with the PDE5 inhibitors. If the patient persists to take 2 drugs at a time in the night, we will be asking his physician or her physician to shift it to the ACE inhibitors, so that there won't be any drug-to-drug interactions. Next question, please.
Okay, sir. Our last question for the day. This is by Dr. G. Mohan from Hyderabad. What would be the drug of choice in sexual dysfunction or erectile dysfunction in patients with type 2 diabetes as a comorbid condition?
Yes, all stalwarts are here. They can throw light on this. We will first go to Dr. Shalini.
Thank you. Yeah, diabetics are the biggest group of people with erectile dysfunction. We see same thing that we've discussed again and again so far. PDE5I as a first line, but do check the testosterone, because if they are hypogonadal, it may be increasing their abdominal girth, and it may be contributing to resistance. So, and sometimes giving them back the testosterone will help give them the energy, get them back to losing weight, improve their diabetes as well. So if they're not hypogonadal, then PDE5I first.
Shamshul Bhai? Unmute.
For diabetes, usually we need a higher dosage.
Excellent.
Usually, if you give someone 5 milligram, for them with diabetes, with poor glycemic control, may need a longer dose, maybe 20 milligram. And also, there are some strict dietary advices and some lifestyle modification as well. Because if you develop diabetes, if it is long-standing, poor glycemic control, there are other issues. Like there will be dyslipidemia, there will be autonomic neuropathy, there will be peripheral neuropathy. So all this will have a cumulative effect. But last but not the least, never think the diabetic patient can also have psychogenic ED as well, because once his performance gets down, so it creates a vicious cycle, and the performance anxiety is on. So it has got all the effects on board. So we have to have a dietary restriction. We have to have a lifestyle modification. And at the same time, if the diabetes causes other comorbidities, we have to treat the other comorbidities as well.
So all these things we have to keep in mind when we are prescribing ED patient associated with diabetes. Because diabetes, the response will be poor for sildenafil, for PDE inhibitors. The dose escalation may be needed. But before dose escalation is advocating, use at least 4 or 5 times, then escalate the dose to maximum to safest level. And at the same time, research has clearly shown that the failure rate is very high in diabetics, uncontrolled diabetics. That's also we have to keep in mind. Otherwise, it goes very well with them. So as you rightly said, patient counseling, appropriate dosing, and periodic checkups will bail them out from this problem. Ritu, you want to add anything for this?
No, sir. Agreed with you.
So now, last question over or any more questions?
Yes, sir. We're done with our questions. So
I want to thank my panelists and all the viewers for their excellent contribution, and they shared their expertise, and I hope this will be useful for all the healthcare providers who have visited the webinar. I thank one and all. Now back to Aishwarya ji.
Thank you, sir. I request Dr. Shalini Andrews to give us one take-home message for today's session, CME.
Be open, be willing to speak to your patients, and be non-judgmental. And let's do this together. It's a journey we undertake with our patients.
Thank you, Dr. Shalini. I want to thank all our speakers, our international speakers, Dr. Shalini and Dr. Mohammad Shamsul. Thank you so much. A big thanks to Dr. Venkatramana sir and Dr. Ritu Sanfani ma'am. Thank you. It was a pleasure to have all of you and hear and learn from all of you. We look forward to see you in our live programs. I also want to thank Sexual Medicine Committee, FOXY, for partnering with Zydus. Zydus Fotiza is dedicated in spreading awareness on sexual medicines and interesting CMEs. So I request all our viewers to stay tuned for those CMEs. Thank you. Thank you, all of you.
Thank you.
Okay. Bye.
Bye.
Big thank you to our moderator Venkatraman sir also.
Thank you.
Yeah.
Thank you, sir.
Yeah. Bye.